Welcome to the Silicon Valley Health Institute. We are a nonprofit 501c organization where we bring the best experts in the whole world for you so you can be proactive in your health and you know what steps to take to be healthy. You can find out more about us on our website, www.sbhi.com, as in Silicon Valley Health Institute. You can join our meetup. We're on MeWe, Facebook, Nextdoor, at least locally. So join. And if you want to be on the email list, send me a private message and we will add you to the email list. Well, today we're very honored having Stephen Sinatra, who's one of the almost founders of the functional medicine movement, the metabolic cardiology movement, moving us from the cholesterol as a demon model to, wait a minute, let's use natural remedies and do something to support our health. He's one of the pioneers, basically, as far as I can see, started this movement. So it's truly exceptional. I mean, he's written, 12 books, cardiology, earthing, asking questions about earthing. And very interesting, it's asking questions about reaching beyond and other, just ask about that. That's interesting as well. Anyway, he's a cardiologist and psychotherapist with over 40 years of clinical experience treating heart disease. He's truly a pioneer and very spiritual. He's one of the most spiritual men I met, and just being around him just feels enlifting. His books include the Sinatra Solution, Metabolic Cardiology, Reverse Heart Disease Now, Lower Your Blood Pressure in 8 Weeks, Heartbreak and Heart Disease, and also a book on earthing. He's delved into the time-honored healing techniques of earthing, where we can connect with the healing energy of the earth. He's a pioneer in many areas, and I'm honored to present him to you here today. Welcome, Dr. Sinatra.
Oh, thanks so much, Susan, for that kind introduction. That was very sweet.
Well, it was minimal. I could go on 1,000 times more.
Well, okay. Well, anyway, how much time do we have to share CoQ10 with the audience? What's the time frame?
It's
Total
a 2
2 hours.
presentation.
2 hours, and you can do it any way you want. Questions, presentation, breaking it up as you like.
I'd like to make it informal because there's a lot of information on CoQ10. So if anybody has a question and wants to stop me, I'm happy to entertain a question anytime.
Good. And also, can you tilt your screen
Yes.
down a little bit so that there we go.
Is that better?
Yes. And also, can you do anything to increase the light that's coming from in front of you?
Is that
perfect? Thank you.
Every good show needs a director and a producer, right? Is that a little cat or a dog next to you? Susan, what is that?
2 Labrador retrievers.
Oh, I love it. Oh my gosh, that's great.
I can't cage them because they'll bark all the time. This is the minimal disruption route.
That's kind of interesting because I learned a lot about coenzyme Q10 through my own pets. I had dogs for decades, and I had an elk hound and 2 chows, and I gave them CoQ10 when they were puppies. And this is an amazing story because my elk hound lived to almost 16, which is unheard of for an elk hound. And my 2 chows lived to 15. And the average age of a chow is 12. So I started CoQ10 when they were like 9, 10 months old. And then I gave them fresh sardines and fresh fish and CoQ10 varietal foods. And then I gave them CoQ10 drops right out of the bottle. And I was amazed. I was absolutely amazed. Their coats were beautiful. They were healthy. And they outlived their counterparts by years. So, I mean, CoQ10, I not only studied it in the rat model and the equine model, but just in my own personal, I didn't publish this at all, but my own personal affiliation with my own pets, I use CoQ10. So I'm all in on CoQ10, and I want to let the audience know that. And the way I'll start this is basically, I want to start this with the moonshot. When we went to the moon in 1969, I was a sophomore in medical school. And the reason why I showed this shot was because while I was in medical school, and there's been great discoveries since we went to the moon, years ago, my greatest discoveries have been in CoQ10 and grounding. Susan mentioned grounding, and they're both connected. And how is that? Well, they're both electron donors. In other words, CoQ10 donates electrons in the in a mitochondrial chain. It hands off electrons, and it generates ATP. Now, grounding drives ATP in the same type of direction, and it also supports blood thinning like CoQ10 does. So they're both connected. And if we realize that hyper blood viscosity, in other words, in the 20th century, because of the computers, EMF, cellular phones, cordless phone, insecticides, pesticides, mercury, heavy metals, you name it, our blood has become like red ketchup as opposed to red wine. And hypercoagulable blood is really the buzzword going forward in the 21st century. The old Framingham data, you know, where we looked at uric acid, blood glucose, cholesterol, all those risk factors, it's become sort of a dinosaur. If your blood is like red ketchup, you're at risk for a cardiovascular event. If your blood is thin, you're in good shape. And basically, that's what grounding and CoQ10 do. They both thin the blood. And this topic is going to be on metabolic cardiology, which to me is one of my greatest discoveries, because it's an opportunity for stem cell renewal. And I'll get into that, you know, in a few minutes. I just want to go over my personal history with CoQ10 because it's kind of interesting. I became a board certified cardiologist the exact same year when Peter Mitchell won the Nobel Prize in CoQ10. And I started using it around 1980, 81, 82, around that area in my patients. During this time, I communicated with Frederick Crane. Now, Frederick Crane was the one who discovered CoQ10 with his PhD candidates at Purdue University. And this is back, you know, decades ago. And then there was Carl Folkers. He was the one that worked for Merck Pharmaceuticals that took the substance from Frederick Crane, and he was the one that devised the formula. And then unfortunately, Merck Pharmaceuticals sold it to the Japanese. So the Japanese became the original manufacturers of CoQ10. Originally, it was CoQ7, then it went to CoQ10. And then in the 80s, I lectured all across the country on CoQ10. I became very enamored with it because I was seeing incredible results in the late 80s and early 90s. And then I presented the Affinity Award to Carl Folkers at the A4M. I was actually there at the meeting. We had about 2,000 people in the audience. And it gave me a lot of joy to present him that award. Back in 1998, I published works on, papers on the bioavailability of CoQ10. And then in 2002, with my son, Drew, he was a senior at Franklin and Marshall College. He did a rat study with CoQ10, and that was published. And the rat study was kind of interesting because I heard an anti-aging rat study presented at the A4M about 5 or 6 years ago. And I wanted to replicate the results because the results were kind of cool. In our study, we took these rats and we gave some rats CoQ10 and some rats placebo. And the interesting thing was that the rats that were getting CoQ10, not only did they outlive their counterpoints by several days or weeks, but they had better coats, they had more activity, and when you put them in a maze, they had greater locomotive activity. They were rearing more up. They found their way through the maze when the other rats couldn't, the older rats. In other words, the older rats, I suspect, had Alzheimer's disease. They lost their memory, but the younger rats, I mean, quote, they looked younger, but the same age rats getting CoQ10 were able to navigate through the maze like it was easy for them. So we published that paper. And sure enough, does CoQ10 help the brain? Absolutely. Does it help with Alzheimer's disease or preventing? Absolutely. So at the end of this study, or at the end of this lecture, I should say, I'm going to show you a study that came out only in mid-November. And it talks about not only the cardiovascular uses of CoQ10, and I'm going to show you that slide so you can go look at it yourself. But the name of the paper is CoQ10, Novel Formulations and Medical Trends. And there's a whole section on there about the non-cardiac exciting conclusions about CoQ10. So that's going to be my last slide, because in the last few years, there's been an explosion in the literature on CoQ10. I mean, it's absolutely mind-boggling. Even this year alone, there were 2 papers in 2020 in April that were really good. Another paper, the paper that I'm going to show you at the end of the lecture in November. But I have to tell you, it's just an amazing substance that's getting more and more play in the literature. And the reason being is this. We used to think that aging had to do with hormones, which hormones do contribute. I mean, no doubt about it. Should females, take progesterone or let's say estradiol or things like that? Absolutely, especially if they're aging. Should men take testosterone? Absolutely. I mean, I believe in a hormonal theory of aging, but if you combine hormonal interactions with incredible mitochondrial support with CoQ10, to me, that's the sine qua non of blunting the aging response. So that's what I'll discuss in the lecture as well. So, in that personal history, I use CoQ10 in a lot of pediatric cases. I got to tell you, I saw so many kids in my office waiting for heart transplantation. And the problem was there wasn't enough hearts to go around. And these parents, they'd be crying in my office because kids were in heart failure. They had enlarged hearts on x-ray. They were in chronic heart failure. And basically, I put these kids on CoQ10 and magnesium right off the bat. And then when I learned about carnitine about 10 or 15 years later, and then ribose about 5 or 10 years after that, this whole metabolic cardiology program came together. But these kids who they couldn't find heart transplants were living. And it was amazing. A lot of these kids, a heart became available 2 or 3 years afterwards, or even 5 years. And some of these kids refused because they were feeling so good. And the parents would come to me and say, "Doctor, what should we do?" And I say, "Look, I mean, this is your choice and your child's choice. I mean, if it were me, I would stay with my own heart, And I even heard about cases from South America. A reporter came up from South America and he met me in Florida, and he did a whole thing on CoQ10 because he had a daughter with tetralogy of Fallot, which is deadly. There's no doubt about it. All these kids died because it's a very complex, congenital heart disease with a lot of moving parts, and the hookups are all, out of whack. So he couldn't afford the $700,000 operation on his daughter. So he learned about metabolic cardiology from one of the doctors that went to my lectures at the A4M. And then he saw this doctor in San Paulo. And then I get I almost cried. I got a video of this girl. She's 15 years old now. She never had the surgery. To my knowledge, she's the only living tetralogy of Fallot in the world without surgery. And, she only weighs about 70 pounds. I mean, she's frail and small, but she's alive. And she sent me this beautiful message. She spoke English, and it was a video that absolutely, brought tears to my, to my being, because, without metabolic cardiology, she would have passed. And again, these operations are like $750,000 on up. I mean, they were very, very expensive operations, very, very complex. So metabolic cardiology is sort of it's an energy type of phenomena where we bring more energy into the heart. And thoracic surgeons knew this for years. I mean, even when I was, even before I learned about CoQ10, when we were doing bypass surgery at my institution, the surgeons were given glucose, insulin, and potassium. And what do they all do? They increase myocardial ATP. And, magnesium was given in a lot of these patients because it increases enzymatic reactions. And then if you look at CoQ10, carnitine, and D-ribose, they all support energy in the myocyte. In other words, they do it by different mechanisms. I mean, CoQ10 plays a vital role in ATP production. The carnitines are like a ferry boat. They shuttle in fatty acids to be burned. And remember this, the brain uses glucose, but the heart uses fat for energy. The heart uses some glucose, but it mainly relies on fat for energy. So when you're shuttling fatty acids to be burned as fuel, and you take out the toxic metabolites, that's what the carnitines do. And D-ribose is really the energy substrate. I mean, let's face it, D-ribose is the 5-sided ring of ATP. It's, and I'm going to show you a picture of that. So basically, if you use these nutrients in combination, you're providing the heart with the secret sauce of energy. And remember, a heart in heart failure or a kid suffering from congenital heart disease, these are energy-starved hearts. So the therapy is to bring energy back into the myocardial. So there we have it. I mean, congestive heart failure is an energy-starved heart. The role of ATP is vital, especially in the heart cell, because the essence is we want to increase the pulsation of cells. I mean, you know, even prehistoric man, I mean, he knew that pulsation was the essence of life. I mean, if you don't have pulsation, you're dead. I mean, that's, you know, that's why I'm so involved in, you know, energy medicine, because it's all about, you know, the role of the cell pulsating. And we do know if we biopsy hearts and heart failure, the ATP concentration in heart cells diminishes. So there we have it. You know, we have histological support of diminished ATP. And so the secret now is to bring back ATP into hearts.
Doc, can I interrupt you for a second here? If you take your cursor on your screen to the bottom of your PowerPoint system, way down on the bottom margin, there's a bunch of symbols there. And on the right-hand side, there's something that looks like a screen, a computer screen sitting on a stand.
Right.
Can you click that?
Sure. Is that better?
Right. There we go. Now we got a bigger screen for everybody to see your slides better.
Oh, okay. That's why we need a computer guy. That's great.
Okay.
So anyway, I got to tell you this. This was a article by the Norway Swedish researchers, Dr. Bergman and Freisen. And this was back in 2009. And I'll never forget this. I came across this article and it gave me great joy. In other words, I was so joyful. You know, when people experience joy, it's just it's an overwhelming vibration of the body. And the reason being was that this was the first article I realized that there's something about metabolic cardiology that, you know, I couldn't understand why these patients were living longer. You got to remember, when I went to medical school back in the 70s, late 60s, early 70s, the 5-year survival of heart failure was much worse than cancer. I mean, our professors would say that all the time. And then when I started to use metabolic cardiology, I was seeing patients living 10, 15, 20, 25 years with low ejection fractions. And I couldn't determine why. I had hunches, I had ideas, I wrote about it. But when this article came out 11 years ago, and by the way, I'll show you another slide. It was recapitulated back in 2017 again. It just blew me away. And what it means is this. You know, back in the Cold War, in the 1950s, late 40s, there was a lot of atomic testing being done in Arizona, Nevada, Utah, those areas. And because of carbon-14, you know, we all breathe it in, you know. We can tell the age of all our cells because of the nuclear testing that was done, you know, in the deserts, right? Now, this is kind of interesting because we all know that the cells in our mucous membranes of our nose and throat live, you know, 2 or 3 days. Our blood cells live 120 days. Our GI tract, the cells live in a GI tract for maybe 4 or 5 days. But we're always reproducing cells. But we never realized that we could reproduce cells in our organs, like heart cells. I mean, that was something that nobody believed in. In other words, we were born with a heart, and we couldn't regenerate the heart. We couldn't renew the heart cells. But then when this atomic testing came out, now we can determine the age of our heart cells. And this is unbelievable. And this is what we call myocardial regeneration. So when I was seeing these miracles, when I was seeing people that should be dead who were living with metabolic cardiology, and there's dozens and dozens of them, when I was seeing these people, I couldn't figure it out. Why? I didn't realize. And they go on and on. Here's a guy, Tommy. I'm a young guy here. He had heart failure. He was a real estate developer. He was ready to go down and see Dr. DeBakey in Houston, Texas for a heart transplant. His doctor heard me lecture at a lecture, and all of a sudden he went on just CoQ10 and magnesium. And then 3 months later, his heart was normal, and he didn't have the operation. And then this is a slide I wanted to show you. Actually, it came out in 2016, early 2017. It was December. And these researchers at the Karolinska Institute were looking at cardiomyocyte renewal. And they recapitulated the same information, that heart cells have the capability of renewal. Think about that. They can regenerate. In other words, if you have dead heart cells from a myocardial infarction, or if you have cardiomegaly from, let's say, longstanding hypertension, and you have dead heart cells and your ejection fraction is compromised, well, it's pretty cool. You can rebuild new heart cells into your compromised myocardium. And that's what all this research was about. So if we look at the mitochondria, and you got to remember, the heart is all about mitochondria, about a third of the weight of the heart. So if you make a fist, that's about the size of your heart, right? A third of that weight are mitochondria. And the essence of mitochondria is that this is where the factory is. This is where the CoQ10 and basically are formed. And what's really cool about mitochondria is that the heart has about a third of its weight, but your other muscle, let's say this is your heart muscle, right? The muscle in my forearm, for example, or my bicep, they only have about 200 mitochondria per cell. The heart has about 3,500 to 5,000 mitochondria per cell. So the heart, because it's pumping 24/7, requires energy. So it makes sense that an energy-starved heart is a failing heart. And the essence of heart disease is to provide more energy to the heart. And that's why we use these, substances. Now, 20 years ago, I was in an American College of Cardiology conference in Southern California. And I heard this cardiologist from England get up, and he gave a nice talk, but he was talking about 100,000 cases of new onset heart failure in Great Britain. And then he says 39,000 were of unknown cause, idiopathic. And I'm sitting in the audience there and I'm going, my God, what is he smoking? What is wrong with this guy? Idiopathic? Are you kidding me? Immediately, I knew it was due to low CoQ10. I really resonated with it. It was all about mitochondrial failure to me. It was about inflammation. And then I was thinking, I said, there's got to be an ATP nutraceutical solution. And this is 20 years ago, right in the middle when I'm publishing papers and books on CoQ10. So it was an ideal aha moment for me to really, see, another board certified, researcher from the other side of the ocean, and we're on different sides of the fence. I mean, we are totally distant in our reasoning and thinking, but again, it doesn't matter. All we want to do is get people better. So if we look at the bench, a bench-side, doctor, let's say a PhD, as opposed to a clinician, we look at a failing heart. We know it's viable and dysfunctional, but it's not irreversibly damaged. I mean, that's what I learned about my young kids when I was giving them these cuts. It's not totally damaged. These are not dead cells. These are cells that are starving for energy. These are cells that are dysfunctional, but they're not wiped out. So heart failure is an energy-starved heart. We have to support the cardiomyocyte. So basically, the way to treat heart disease is to bring biochemistry back to the bedside. In other words, we got to bring, as clinicians, we got to be a little bit, erudite in biochemistry at the same time. So there is ATP, the energy of life. And if you look at that center where ribose is, that's a 5-sided purine ring. Ribose is the center of ATP. And I bet a lot of doctors on this call didn't realize that. I mean, you know, we learned this in high school chemistry and biology, in the same way in college. But if we look at ATP, you have an adenine ring to the left, you have a ribose, you know, energy producing source, and you have 3 phosphate groups. And the cleavage of that ATP to ADP is really the energy. And I never met Joanne Ingwall, but I've read her works and we talked on the phone lots of times. But back in 2002, she was a professor at Harvard. She was the one that wrote about ATP and myocardial function. And I just love what she said here. She says, the myocyte needs to grow. It needs to replenish itself to survive. The requirement of ATP is absolute. It's absolute. So we got to give hearts ATP. And we know that when we biopsy these hearts, like I said before, when they're in heart failure, the ATP stores are diminished. So doesn't it make sense just to give the failing heart or any enlarged heart, whether it's myocarditis or from alcoholism or from longstanding hypertension or valvular heart disease, any type of heart situation, we need to give the heart the energy it needs, and that's adenosine triphosphate. So if we look at dysfunctional energy in disease hearts, that can be angina, heart failure, it can be a bypass, or it can be, just angioplasty. And if we look at chronic coronary artery disease with ischemia, this is where ATP drops. Whenever a person develops angina, the symptom is chest discomfort or weakness or jaw pain or arm pain or shortness of breath. It can be, all of the above. But the biochemical alteration is that ATP drops. And I'll tell you, for the doctors on the phone or on this call, how many times has one patient been a messenger in your practice where one patient can come back and give you a response or a verbal interaction where all of a sudden it's changed your whole focus on your practice? I mean, I'm sure it's happened to me. I mean, patients are your greatest messengers. There's no doubt about it. And we learn from our patients all the time. So I had a guy, he had bypass surgery. I cathed him, he had triple bypass. And I saw him about 5 years later, and he started to develop some symptoms. And I don't know whether it was angina or it was a little early for him to develop symptoms, but I put him on a treadmill and he developed ST segment depression. But his ST segments came back after about 5 or 10 minutes. And I was thinking about studying him again with an angiogram, but he was sort of asymptomatic. And I don't like to study asymptomatic people. So I said to him, I said, see me next year. We'll repeat the stress test, just stay in touch, blah, blah, blah. And I see him next year. And then everything's fine. He's not having any angina, but I was worried about his stress test. And I said, I'd like to repeat your stress test. And he goes, Doc, please don't do that. I go, why? What happened? He goes, after the stress test, I walked out of your office. I wasn't feeling right. I was weak. I wasn't myself. It took me days to get my energy back. I go, days? I go, why didn't you let me know? He goes, well, I could function and I didn't have any chest pain, but it just took days. And then I thought about it. And then I realized that when I went to the literature, he had an ATP deficit. And then I said to myself, holy cow. I said, even though he has coronary artery disease, when you put him on a treadmill and he develops ST segment depression and he had mild symptoms, but he had an ATP deficit, but it takes the body days to make that ATP back again, and he was on minimal doses of maybe CoQ10. This is before the days of ribose. And basically that one guy taught me that whenever you drop your ST segments down, your ATP is diminished in the heart, and as is the rest of the body. It's almost like a marathon runner who develops cramps, during a marathon in his legs, and they can't get going again. Or an NFL football player. You've all seen it on the screen where they have intense cramps. All they need is ribose. All they need to do is build their ATP, and it comes roaring back. It's amazing. When I fly fish and I walk the beach, and if I get cramps, I carry a jug of ribose with water, and I just drink ribose, and the cramps go away within minutes. It's unbelievable. because that's how quickly ribose builds ATP. It's the center of the ATP molecule. So one guy just taught me an amazing amount of biochemistry and cardiology. So any intervention that will slow down ATP degradation or speed up recovery will minimize heart damage and enhance cardiac function. It just makes sense. And how do you do that? Well, it's all about metabolic cardiology. In other words, you just give CoQ10, carnitine, D-ribose to restore ATP dynamics. So if we look at these slides, we see that D-ribose results in the synthesis of new ATP, and carnitine and CoQ10 increase the turnover of ATP. Very, very important, because when you bring those two entities together, now you're generating energy for hearts that are energy starved to begin with. And if we look at ATP, we know that it supports systolic contraction, but more importantly, and I want you to understand this, it supports diastolic relaxation. Remember this, it takes more energy to fill a heart with blood than to squeeze the heart with blood out of the heart. In other words, diastole requires more ATP. That is so important because remember, the ionic pumps, the calcium pumps is diastole dependent. So if I show you this slide, this looks like we have more energy in kilojoules on the left of the slide. It goes from 70 to 40. We know that the sodium potassium pump requires 48 kilojoules per mole. So that's systole. We're talking about the sodium potassium pump. When the heart contracts, you're generating 48 kilojoules of energy. However, when the heart is filling with blood, you're generating more energy. In other words, it requires more energy to fill the heart with blood than to empty the heart. So that's the calcium pump. And that's why these people need ATP, because when ATP levels drop and you drop below 50 to 48 and people do that, now you're struggling with your heart. Your heart function is struggling. That's why this biochemistry is so important. And we realize that whenever we have ischemic stress or chest pain where ATP drops, now we're losing ATP, because what happens is ATP goes to adenosine monophosphate, and then it gets crossed over into the plasma, and we lose our purines. In other words, when we have ischemia, it goes to uric. When inosine forms hypoxanthine, it goes to uric acid. And this is amazing. I saw a guy, I ended up doing an angiogram on him, and he had a very tight LAD, about 95%. So he had an internal mammary implant to his LAD, but he had a very small diagonal vessel, very tiny diagonal that was about 90% occluded, but the surgeons could not fix. It was a very, very small vessel, and it didn't matter. We fixed his LAD, and his right had a little bit of disease. His left circumflex was okay. So we figured we did a good job. No, we didn't. He goes home from the hospital, he recovers, and he's still getting angina. I go, how could this be? And I reviewed the angiogram. I went over the case with the surgeon again, and we saw that he had this little diagonal. And I said, uh-oh. I said, he has an unsatisfactory quality of life. And then I did a blood screen on him, and his uric acid is like 7. It's like off the charts. I go, what is going on here? I go, do you have gout? He goes, no, I don't have gout. I go, have you ever had gout or arthritis or painful joints? He goes, no. And then I realized what was happening was he was losing his purines, and it was being degraded to uric acid. So this is an amazing case. As soon as I put him on metabolic cardiology, as soon as I put him on ribose, carnitine, CoQ10, what happened was I replenished his, ATP pool. He was, still having silent ischemia, but now he wasn't having any angina. In other words, the quality of his life went up. It was like unbelievable. And I wrote about him in one of my books. Again, another messenger where once you restore that energy to the heart, the symptoms just dissipate. Just an amazing case. So if we look at heart function, about 550,000 new cases of heart failure occur a year. Now, a lot of this heart failure is diastolic dysfunction. This is something that a lot of cardiologists, even today, don't understand, because there's no drugs that can fix diastolic dysfunction. There's a little information about ACE inhibitors and second generation, third generation ACE inhibitors, but diastolic dysfunction is an energy-starved heart. It's where diastole, remember, it takes more energy to fill the heart. And with this more energy, what happens is that we have to give energy to a heart that's struggling with energy. And we know that diastolic dysfunction occurs more in women. And this is amazing because the average age of women over 45, about 28% of men and women, but mostly women over the age of 45, have diastolic dysfunction and they don't know it. And the symptoms are sort of quasi. The major symptom of diastolic dysfunction is shortness of breath and fatigue. And the problem is diastolic dysfunction can occur in mitral valve prolapse, and it can occur in high blood pressure. And remember, high blood pressure is more common in women than in men. And more women take more nonsteroidals, which can cause hypertension in women, the Motrin type derivatives, the Advil. And what happens is a lot of women get heart failure as opposed to men. So if a woman develops diastolic dysfunction, let's say when she's 45 or 50, she may develop systolic dysfunction when she's 65 or 70 or 75. And that's not cool, because now she has, heart failure. And a lot of this can be prevented. But remember, more women get more mitral valve prolapse than men, and more women have more significant complications from hypertension than men. And the reason behind that is that a woman's heart anatomically is smaller than a man's, and a woman's vasculature, her coronary vessels, are smaller than a man's. That's why when it comes to PTCA and stents and bypass surgery, a woman's anatomy is more difficult to work with than a man's anatomy, and that's why women have more complications. So that's why it's important to treat women, if you can, non-surgically, as opposed to men. So diastolic dysfunction, again, more common in women with hypertension, hypertrophic cardiomyopathy, mitral valve prolapse, and infiltrative cardiomyopathy. I mean, I've seen more women with infiltrative cardiomyopathy, whether it's myocarditis, even more sarcoid occurs in women, and hypertrophic cardiomyopathy is about equal. So diastolic dysfunction, where the heart is struggling with filling of the blood, is an early sign of myocardial failure despite adequate systolic function. And we know that diastolic function requires more cellular energy. And with statins, for example, we're seeing more cardiomyopathy or more heart failure with long-term use of statins. Because why? Statins diminish the endogenous production of coenzyme Q10. And whenever you do that, you run the risk of diastolic dysfunction, because CoQ10 is necessary for the energetic considerations of the myocardium. So if we look at diastolic dysfunction and mortality, this is an echo paper that came out, and this really blew me away. This, because I used to read 25 to 30 echoes a day when I was in practice. And I used to read them for the hospitals and my private practice. And I had a lot of experience with echocardiography. And this study looked at 36,000 persons with echocardiograms for almost a decade. And basically, 2/3 of patients had diastolic dysfunction, but didn't know it. They had, in other words, no symptoms, but they had it by echocardiographic analysis. The problem over the last 10 years is that a lot of doctors have not been reporting on diastolic dysfunction because there's no drugs that treat it. That's the problem. There's no really drugs that treat it. And basically, authors, when they talked about this in papers, they had no solutions. But metabolic cardiology, in my mind, is an absolute solution for diastolic dysfunction. So is diastolic dysfunction a growing epidemic? Yeah, it is. It's no question. I mean, we see it in bypass surgery. We see it in all forms of cardiac disease where patients don't think they have it because they think they have a little bit of high blood pressure, or a little bit of mitral valve prolapse, or a little of this, a little of that, and it just goes over their head. But diastolic dysfunction is a real entity, and you have to treat it with biochemical considerations. Now, we know that there's an imbalance in energy, and we know that biopsies from the American Journal of Cardiology journal back in 1987 showed diminished quantities of ATP. And we know that if we look at the atrium and what happens in the atrium in atrial fibrillation, we know that these energetic adaptations occur with atrial fibrillation as well. In other words, we're getting a defect, a diminished deficit in ATP. So if you look at some of the trials on CoQ10, there was one trial where they gave 300 milligrams of CoQ10, and it actually preserved mitochondrial function and an improved diastolic function. And then we look at other studies with ribose and CoQ10 and carnitine. This whole aspect of metabolic cardiology was coming into fruition. And then the essence of metabolic cardiology is really CoQ10. And this is the backbone of metabolic cardiology. We call CoQ10, it's 2,3-dimethylhydroxy 5-methyl-decaptophenyl 1,4-benzoquinone. I mean, it's unbelievable. That's the chemical name. It's shaped like a hockey stick. In other words, the CoQ10 molecule, and then it has what we call an isoprenoid chain. So it's a very, very large molecule in the body. And the history, I just want to go over because, again, it's kind of cool. I told you about Fred Crane in 1957. Dr. Lautaro, he was the first one where it's been like 50 years, where he showed CoQ10 deficiency in human heart disease. In the mid-70s, the Japanese were able to really produce it in large quantities. I told you about Peter Mitchell getting the Nobel Prize in 1977. Dr. Langston in Texas, he was a cardiovascular surgeon. His son's a cardiologist, and he really did incredible work on CoQ10 back in the 1980s. In 1992, when I was chief of cardiology at my institution, I actually placed CoQ10 in our formulary. We were the only hospital in the United States to have CoQ10 on its formulary. In other words, when patients came into our CCU, any doctor in our hospital could prescribe CoQ10 in the CCU and give patients, oral CoQ10. I had it passed, but by the Pharmacy and Therapeutics Board, and I have to tell you that I believe in my own heart that we had an incredible survival rate in our CCU because we gave our patients, whether they were in heart failure or refractory arrhythmias or in myocardial infarction, we gave these patients early CoQ10. And the literature proves it out that CoQ10 absolutely increases survival in patients with any form of heart disease. Back in 1996, I presented a few cases to the International Society. And what I told the society, there was about 500 of us from all over the world using CoQ10. I showed refractory cases of heart failure that required 7 times the blood level of CoQ10. In other words, a normal blood level of CoQ10 is like 0.5 UGs per ml, 0.5 to 0.7. In these cases, the only way I got reversal of heart failure was by getting the blood level up to 2.5 UGs per ml. It's almost like using ACE inhibitors. For you doctors on the call, remember you would use 3.75 of ACE inhibitors and double it and double it. Or use low doses of digoxin and then double it. Or use low doses of antihypertensive meds and then double it and double it. Same thing is with CoQ10. In other words, you need to build a therapeutic blood level where you get a therapeutic response. Because some papers that were produced in the literature where they didn't get a therapeutic response, they had subpar blood levels. So it's like anything else, whether it's a pharmaceutical agent or a nutraceutical agent, a blood level is very, very appropriate. And then back in 1997, Tishkon developed this biosolve process that is unbelievable, but raising the blood levels of CoQ10. And I was working with their PharmD people, and it was just amazing. We wrote about CoQ10 in the textbooks of cardiology in 1997. The Canadian government actually put the word ubiquinone on any prescription with statins because they knew that statins can diminish CoQ10. So they wanted to make the health professions aware and the doctors aware that if anybody taking a statin, they should take a CoQ10 as well. Back in 2005, at another CoQ10 conference, we realized that double dosing was better than single dosing. So we like to give CoQ10 twice a day. Canica introduced ubiquinol back in 2006. I'll get into the ubiquinone MitoQ situation later. In 2008, the American Journal of Cardiology showed that people taking CoQ10 live longer with heart failure. In Down syndrome, CoQ10 reduces oxidative damage and is really good for the brain in Down syndrome. The Q-Symbio study came out in Portugal in 2013. It's been published in the literature in 2014, and again recapitulated in 2019. And what the Q-Symbio study shows is that, again, better longevity in patients with heart failure taking CoQ10. And then from 2014 to 2020, there's been an explosion in the literature. I mean an explosion in the literature. I mean, even the Japanese researchers are reporting, like the skin, for example, women who have crow's feet around their eyes, or men, they were showing, and they were doing this with biopsies, where that if you took CoQ10, you had better aging of the skin. And I'll tell you, there's not a woman alive that wouldn't gravitate to that, In other words, this is amazing stuff that I'm finding about on CoQ10. And this is a paper that only came out last year, but this an incredible explosion. Now, these control trials on CoQ10, there's 60 with benefit, 4 with no benefit. And these last 2 trials, I even sent a letter to the editor, this Maryland study and the Australian study. They used insufficient qualitative amounts and quantitative amounts of CoQ10. They only got blood levels up to 1. It's not going to work. So no wonder why these trials failed. And, like I said, you need a decent blood level like anything else, So if we look at CoQ10, it's in the membranes of mitochondria. The reduced form is ubiquinol. The oxidized form is ubiquinone. But remember, the body transfers this back and forth simultaneously. A gazillion times a minute, ubiquinol and ubiquinone are interchanged. Now, is there an advantage of ubiquinol? There might be in these very bizarre congenital, syndromes like Myocardial syndrome, Friedreich's ataxia, any of these very, very bizarre congenital syndromes in children. There might be an advantage of ubiquinol over ubiquinone because these children are starving for energy. And if there's any benefit, I think that's what it would be. Remember that CoQ10, we talked about the heart cells versus skeletal muscle. It's a definite energy transfer molecule. It has antioxidant, anti-inflammatory, and ATP functions. And it's a great adjunct in cardiovascular disease, angina, CHF, atrial fibrillation, lipid disorders, diabetes, and hypertension. It inhibits peroxidation of a cellular membrane. Very important about CoQ10. Listen, we all worry about cholesterol. Everybody's worried about cholesterol. But if it's not oxidized, who cares? Who cares if you have high cholesterol? It's oxidized cholesterol that causes endothelial cell dysfunction. And one of the things CoQ10 does, it prohibits the oxidation or the lipid peroxidation of your cholesterol. In other words, it helps prevent lipid peroxidation. That's why everybody should take it. I'm telling everybody anybody listening to this broadcast should take CoQ10. I mean, I take it every day. I mean, I've been taking it every day for years. Now, in vitro, CoQ10 inhibits LDL oxidation more than beta carotene and alpha tocopherol. So that's kind of cool too, to know. Now, CoQ10 cardiovascular effects. This is big, folks. This is really big. Lp(a) is the real cholesterol story. In other words, everybody worries about HDL, LDL, dysfunctional HDL. My LDL is too high, blah, blah, blah. It's Lp(a) that's the true inflammatory component. This is a component that I want to neutralize in people. And the problem is, since the Biogenome Project came out, where we mapped our genetics, and this is about 20 years ago, we realized that Lp(a) is more expressed in the population. And this is one risk factor that needs to be at least analyzed in any family history of a heart attack, whether it's young or old, anybody in a family history, because if you do have high Lp(a), you must neutralize it. This, to me, is the most toxic cardiovascular risk factor. Why haven't the doctors heard about it? Because there's no drugs that treat it. Every single drug trial trying to treat Lp(a) has failed. And statins even increase it, and they can make Lp(a) worse. CoQ10, there's good data to demonstrate that it reduces Lp(a). What can really neutralize it? Nanokinase can do it. I like lumbrokinase. If any of you are listening from Canada, the trade name is Beluki. I think Beluki is awesome. It's a fibrinolytic. It thins the blood, and it has a direct impact on Lp(a). So, those are my remedies for Lp(a). Again, CoQ10 is something that anybody should take with high Lp(a). CoQ10 improves endothelial function. It decreases cholesterol, triglyceride levels, increases HDL. It does everything right, folks. It does everything right. It decreases fasting blood pressure and fasting blood sugar, and it lowers hemoglobin A1C. I talked about reducing LDL oxidation. It also reduces systolic blood pressure, but in my experience, in the literature, it reduces systolic, but I've had patients, my own personal patients, where it's reduced diastolic blood pressure as well. It has a direct effect on the endothelium in promoting vasodilation. Improves nitric oxide. Now, nitric oxide can be a blessing or a curse. I mean, you've heard a lot about nitric oxide. How should I say this? It can rescue a lot of people. A little bit too much of it can have a downside. Like everything else, there's a sweet spot to nitric oxide. If people get it from foods like kale or migratory salmon or sardines, I'm all in. If you get it from CoQ10, I'm all in. If you take nitric oxide supplements, be a little careful just not to overdo it, because I think there's going to be literature in the future that's going to talk about a downside if you have too much in the body. But it's like anything else. Too much vitamin E is not good for you. Too much beta carotene, is not good for you. I mean, it's like anything else with nutraceuticals. There's always a sweet spot. But anyway, I'm pro nitric oxide. I want you to know that. But again, caution in taking it in high doses or eating a lot of foods continuously with nitric oxide. Definitely reduces blood pressure. And in my experience with CoQ10 and blood pressure, I've had several of my patients on CoQ10 lower diastolic blood pressures as well, especially when they sleep grounded. When they sleep grounded and take CoQ10 at the same time, I've had many patients able to get off all hypertensive drugs with that combination. It's a great combination. And remember my first and second slide, they share a similar path. So grounding and CoQ10 are like kissing cousins, so to speak. Now, in heart failure, we talked about mitochondrial dysfunction. We talked about the decreased production of ATP. There's an increase in reactive oxygen species of free radicals. We get endothelial dysfunction, and the prognosis is poor and is usually a compromised quality of life. The Q-Symbio study I mentioned in the previous slide, this was recapitulated again, but again, just to show you that in these very, very sick patients, the placebo patients did far worse in hospitalizations and actually death. I mean, this is this is one study you can take to the bank, because the patients with profound heart failure did much better on CoQ10. Now, there was a post hoc analysis. I gave you the slide by Mortensen and Rosenfeld et al. That's 2019 double-blind trial. This is a post hoc analysis. And again, they just recapitulated the data, and it showed a reduction in hospitalizations and a reduction in all-cause mortality. This is now all-cause mortality on CoQ10. Now, subsequent to that, there was a meta-analysis of 14 trials looking at 2,149 patients, and the average usage of CoQ10, and not a large dose, only 100 to 200 milligrams, there was a significant reduction in mortality versus placebo. If we look at CoQ10 and atrial fibrillation, and by the way, atrial fibrillation is epidemic in our society today. So this is an important one, docs, because I'll tell you this, why are we seeing more atrial fibrillation? Probably because of electromagnetics. Remember all the Wi-Fi, Bluetooth, and now the 5G coming out. The heart is very sensitive to these wireless frequencies, and we're seeing a lot more atrial fibrillation. And remember that if you do use a cell phone towards your ear, or a cordless phone, which is even worse, the radiation is going to your thyroid. You can take out the thyroid, and remember, the thyroid and the heart are very connected with thyroid hormone, and surges of thyroxine and atrial fibrillation. I mean, it's a mess. It's just a hodgepodge. It's a mess. So these are the reasons why we're seeing more atrial fibrillation. A lot of it is due to the direct impact of EMF and also the indirect impact on the thyroid. Patients treated with CoQ10 have less atrial fibrillation following cardiac surgery. Same thing is true with ribose, by the way. So I would love to do a study with thoracic surgeons looking at ribose and CoQ10, because the incidence of atrial fibrillation would be less. And one possible mechanism in the reduction is serum malondialdehyde levels can be decreased with CoQ10. And remember, that's an inflammatory mediator. This is, I want to clear up the ubiquinol MitoQ story. Basically, the most important thing about CoQ10 is its bioavailability. There's no question. The more you absorb CoQ10, the better it is. And if you have a very highly bioavailable form of CoQ10 that gets into the bloodstream, why spend, $10, $15, $20 more a month on ubiquinol? I mean, that's the way I look at it. I looked at trials of looking at ubiquinol and ubiquinone. I've done them myself. And when you use a high quality ubiquinone, it's like absolutely the same. And we have to remember this. The two most quoted studies, the Kysel study. The Kysel study was done in Scandinavia. It's kind of interesting. They looked at 100-year-old people. Think of that. Think of this. They only looked at centenarians. If you're 100 years old, you got into the study. If you were 99, you're out. You're not in the study. And what they found in 100-year-old people was that the combination of ubiquinone and actually the carnitines were awesome in longevity. So that's kind of cool. I mean, I really like that. That's really amazing. Now, in the Kysel study and the Q-Symbio study, they used ubiquinone, not ubiquinol. There's only one study I've seen on ubiquinol, and it showed promise, but I don't know if it's been published yet. But there's no studies of ubiquinol like showing longevity in heart failure as opposed to ubiquinone. Now, I mentioned this before, that ubiquinol and MitoQ may have an advantage in these pediatric patients with inborn errors of metabolism. One of the things about CoQ10 and non-alcoholic fatty liver disease, this is a problem that is becoming more and more apparent in our society today. Everybody's seen the commercials about liver transplantation, and non-alcoholic fatty liver disease is a real problem. There's no doubt about it. Can it be related to GMO foods or insecticides or pesticides? I mean, there's something going on in our environment, and the liver is taking the brunt of it. I can tell you that. But one of the things about CoQ10, is that it helps to battle insulin resistance. And remember, insulin resistance is a part of non-alcoholic fatty liver disease. In other words, there's diminished insulin, sensitivity. So there's a relation to the both of them. Now, there's a mitochondrial protein. We call it mitofusin, MFN2, which protects against liver disease. And we see a reduced expression of mitofusin in non-alcoholic fatty liver disease. The loss of MFN2 may be secondary to a depletion of mitochondrial CoQ10. So the CoQ10 may have a positive impact on non-alcoholic fatty liver disease, although the mechanism isn't clear. What I want to tell you is that since this is happening more and more in society, it's happening more and more in our patients and more in ourselves as professionals, it makes sense. It just makes sense to take CoQ10. I mean, why not take it? It's protecting us against environmental threats right now. Now, the mechanism may be is that CoQ10 may downregulate NF-kappa B. And whenever you downrate this pro-inflammatory mediator, could this be the factor in reducing non-alcoholic fatty liver disease? And it might be possible. And I just gave you some of the references on that because I think it's important about insulin resistance and non-alcoholic fatty liver disease. Now, in type 2 diabetes, now, here's a problem. There's about 35 million to 40 million type 1 diabetics in the country. There's another 30 million type 2 diabetics in the country, and another 20 million that are borderline insulin resistant individuals that are going to become type 2 diabetics. So what am I saying here? There's almost 100 million potential and real diabetics in our society today. And given the fact that diabetes is probably the number one, risk factor against COVID-19 and obesity being second, it makes sense that we reduce diabetes in this country. It just makes sense. And there's lots of ways of doing that. I mean, everybody knows, a non-inflammatory diet, a low cholesterol, a low carbohydrate diet, more exercise, more CoQ10, loss of weight. It just makes a lot of sense, especially in this day and age of COVID. But diabetes, if we have 100 million new diabetics in our society in the next couple of years, that's going to be 1 out of 3.5 people, or 1 out of 3.4 people. This is going to be an enormous strain on our medical resources. So as doctors, we got to educate our patients about avoiding type 2 diabetes. Now, look, I come from a diabetic family. My grandmother was diabetic. My mother was diabetic. And they both developed blindness. And, diabetes is something that we really have to be privy to. I mean, fortunately, my hemoglobin A1C stays low. My fasting blood sugars, they're around 90 to 100. By the way, the best fasting blood sugar is 70 to 80. I mean, you all know that's been downregulated. So it's very important to really put diabetes away from us. In other words, try to prevent it, especially with COVID-19 in this day and era. And by the way, COVID-19 is only the tip of the iceberg. I mean, I really think we're going to be seeing more and more pernicious viruses in the future, but we need to protect ourselves with, biochemical support. There's no doubt about it. What CoQ10 does, it increases insulin sensitivity because it neutralizes a lot of these mitochondrial free radical oxidants. And by the way, CoQ10 has been written up as an early RX for diabetic nephropathy as well. So it's really important because, CoQ10 protects the kidney. I mean, it's just unbelievable, what CoQ10 does. So if we look at extreme insulin resistance to type 2 diabetes mellitus, we see a deficiency of CoQ10 plasma levels when compared to healthy controls. Now think about that. Just boost your plasma level of CoQ10 and you may thwart off diabetes. Consumption of CoQ10 less than 200 milligrams daily reduces fasting glucose, triglycerides, and hemoglobin A1C levels. It just makes sense to take CoQ10. And in the rat model, metformin with CoQ10 showed a better protective effect than either supplement alone, on the kidney. And I was, at the E4M, a lot of my colleagues take metformin, as an anti-aging substance. A lot of my colleagues take berberine. I like berberine. I like metformin. I love CoQ10. I think they're all okay. I really do. I think berberine and CoQ10 could be a magical secret sauce going forward. So they're all good. All we want to do is improve glucose dynamics. And remember, berberine supports AMPK. And whenever you do that, you're driving your enzymatic reactions in the right direction as well. So if we look at dyslipidemias, and I'm coming to a conclusion on this talk, dyslipidemias improves, or CoQ10 improves a nuclear receptor protein that regulates gene expression involved in insulin and lipid metabolism. In endothelial cells, CoQ10 stimulates AMPK and causes a reduction in ROS, or reactive oxygen species. And CoQ10 results in an increased resistance to oxidative stress on plasma lipids. And these meta-analyses I gave you the ones on Lp(a). And remember this, CoQ10 versus placebo reduces the statin-associated muscle aches and pain. So anybody taking a statin must be on CoQ10. There's no doubt about it. And I gave you some of the references there in the dyslipidemias as well. So if we come to a conclusion with metabolic cardiology, mitochondrial restoration and energy support is really the metabolic solution. And we want to use targeted metabolic therapies that can improve myocardial metabolism, and metabolic cardiology gives us great hope. This is one of my case studies. This is Ryan came into my office when his his parents were crying in the office. He was 9 years old. He had severe heart failure. They couldn't find a heart for him. Now he's 32 years old. He's the oldest living singlet outlet ventricle in the world without surgery. Could metabolic cardiology create the stem cells to revitalize and regenerate his heart? Somebody will do that research. I have a feeling that metabolic cardiology talks to the exosomes in our body, and the exosomes serve as chemical messages to turn on the intrinsic stem cells that we all have, in our body. And remember, these intrinsic stem cells can last to maybe 90 years old. So there's hope for even all of us, even in the 8th decade of life. This was Joan, had postpartum cardiomyopathy, severe shortness of breath. Again, was told to get a heart transplant. I treated her with CoQ10. She's in her 70s and doing real well. Diastolic dysfunction on the rise, like I said before. We need CoQ10, carnitine, and ribose, and certainly magnesium for these patients. This is a paper that I want you all to read. I doctored it up a little bit, with that CoQ10 and stuff, but there's the author. It came out in November 2020. This paper blew me away. I have to tell you, I read all I can on CoQ10 because I'm writing a textbook.
343.
I'm sorry?
I'll just sit here and wait.
Oh, okay. So anyway, this paper actually blew me away because it showed not only the cardiac characteristics of CoQ10, but the non-cardiac. And I want to end on that because it's really cool. So the conclusions for today is CoQ10 is an ideal dietary supplement. It's safe and well tolerated. It's great for our cardiovascular risk factors, as well as our endothelial cells and myocardial cells supporting ATP. Reduces inflammation and oxidative stress, and mildly reduces blood pressure, and improves insulin resistance, which is, pathognomonic right now in our society and endemic. It attenuates arrhythmia, both atrial and ventricular. It supports quality of life, especially in patients with diastolic dysfunction and heart failure. And the more surprising conclusions that came out in this paper that came out a month and a half ago, it's just amazing. They were talking about epilepsy palliation with CoQ10, Parkinson's and neurodegenerative disease, dementia and Down syndrome, protection from UV radiation. This is the one that blew me away. I didn't learn this until 6 weeks ago. Glaucoma. CoQ10 rescues the retina from intraocular higher pressures, and it preserves the, the cells of the retina. And this is just amazing because glaucoma runs in my family. My grandmother and my mother both had diabetes and glaucoma. They both went blind. To my knowledge, myself and my three siblings, we all take CoQ10. We all have normal intraocular pressures. We've all been taking CoQ10 for decades. And I'm wondering if it's due to CoQ10, because now it's out in the literature. And that's why I wanted to give you this paper about glaucoma and CoQ10. Familial hypercholesterolemia, pain alleviation, and migraine. This is amazing. Migraine headache is a disaster for a lot of people. But if you take CoQ10 and magnesium, it's a knockout punch for migraine. Because now we know that when people get migraine, the CoQ10 levels in the body drop. So it just makes sense to take CoQ10 if you are a migraine person. And the greatest thing right now with the COVID-19 epidemic is CoQ10 provides immune support. Now, this is amazing because one of the hallmarks of CoQ10 is the ACE2 variant. In other words, when the virus locks into the ACE2 receptor site, enormous endothelial inflammation takes place, resulting in blood clotting. This is why there's a lot of pneumonia, a dry cough, and stuff like that. This is why people get strokes, they get kidney embolization, they get GI disease, eating, even the fingernails, they can get hemorrhages, into the peripheral, vasculature. What CoQ10 does, it downregulates the inflammatory cytokines of NF-kappa B, interleukin 6, and C-reactive protein. So it just makes sense. If you can target the cytokine storm with CoQ10 and knock down the inflammatory mediators, because this cytokine storm in some people is a disaster where they get blood clots in the lung and all over the place. So I just think CoQ10, somebody will probably do this research, but if you can support your endothelial cell function, this is big, where it's endothelial cell dysfunction that could be the harbinger of all these hemorrhagic lesions in COVID-19. So I'll end on that note, thanks for being patient with me, and hopefully we didn't go over too long. So any
Not
questions?
at all. We have 2 hours for you, and you've just used 1 1/4.
Okay, great. So if anybody has questions on anything in cardiology or, even COVID-19, I mean, I've been up on that. I do a lot of radio and TV on that. So I do a lot of reading about COVID. So but anything you want to ask is.
Susan, why don't you go
We have
first?
a lot of questions here, so let's go through them. The first question is, how can we test or detect for ground current pollution, and how can we ground Earth safely in places where there is ground current pollution?
Or recognize where there is a non-safe grounding place because the power pole, for example, has a grounding rod that's dumping dirty electricity into the ground.
Right. There's a lot of controversy on this, and I can understand, both points of view. I mean, some of my colleagues don't believe in dirty electricity, and the reason why they don't believe in it is because the Earth is huge. The Earth trumps everything. In other words, the energy of the Earth. I mean, if you think about it, lightning strikes the Earth's equator about 1,000 times per minute around the equator. And these lightning strikes endow Mother Earth with gazillions and gazillions of electrons. Now, when I'm in Tampa, Florida, the first thing I do after a lightning storm, and believe me, Tampa is the lightning capital of the United States, and I'm down there for 6 months out of the year. When there's a thunderstorm, I immediately go outside barefoot because the atmosphere smells of ozone, and the ground is just alive with electrons. And I go barefoot on that grass, and I just soak up those electrons. Now, I don't live near a power station, okay, in Florida. But if I lived next to a power station, and when I say next to a power station, maybe as much as a quarter of a mile, Uh, I personally wouldn't walk barefoot because I do believe that in certain, there are hot spots in the environment. And I do believe that they can be toxic. Now let's look at antiquity. Do you remember when the Roman legions were fighting in Europe and in Ireland and England and France? I'm talking 2,000 years ago. The Roman legions, their spiritual healers realized that if they walked between point A and point B, there were certain hot spots in the earth that made their soldiers sicker following battles, and their soldiers recovered less. In other words, if you look at where they marched on areas of sacred ground, where a lot of churches were built, so to speak, where they had sacred energies. And it's just amazing if you read these reports where they used, instead of going between part A and part B, they thought there were certain elements in the earth that were toxic and there were better roads to walk on. This is amazing stuff. So I believe both ways. I do believe that dirty electricity, or if there are certain hotspots that can create inflammation. But I also believe that the earth is so endowed that it trumps a lot of these hotspots. But if you do live near a hotspot, I would not walk barefoot. Let me give you one example. In my town here in Connecticut, I verbalized very strongly against, they wanted to put a basketball court for kids to play, kids 8 years up to 16 years old, next to a power station in my town. There's a power station in my town about a mile away. As a doctor, I was virulent against, putting our children 100 feet away playing basketball, from a big, power station. I got turned down. I was called a quack by other doctors in my town because they wanted it, But thank God the townspeople listened to me over the other doctors because they did not put that basketball court there. And then, more research has come out, showing that, this dirty electricity, might be a factor. So I know I gave a long answer. And again, if it were me, I would not walk barefoot near a power station.
Thank you. Susie, how about you?
Oh, are you talking to me?
Well, no, Susie McKee.
Oh, I didn't have my hand up. Sorry. I
Oh,
just was unmuted. Thank you,
were
though.
unmuted. Okay.
Thank you.
Simona.
Thank you. So I have a relative who's on statins and beta blockers. And is there any particular path that you recommend for starting on CoQ10 and possibly ribose and carnitine to transition off them, especially if their doctor has never ever mentioned CoQ10 to them?
Well, the important thing here is, remember, there's lots of drugs that deplete CoQ10. Statins are the worst, but beta blockers do it also. So it's important that she's on 2 drugs that can reduce the endogenous production of CoQ10 in the body. So she definitely needs to be on CoQ10. Now, look, I do like statins. I'm sorry, I do like beta blockers in people. I think beta blockers do a lot of good things, especially low dose beta blockers. Is this a male or a female on statins?
Female.
Female?
Yep. Age 82.
Yeah. Definite history of coronary artery disease?
Takotsubo is what, and
Takotsubo's disease.
and peripheral arterial disease also. So 2 stents.
Well, Takotsubo's disease is it's a real entity. It's a problem.
And the Takotsubo, they said, has been completely resolved, and now she has the heart of a 20-year-old.
Yeah.
But she's still on these 2 drugs.
If this were my patient, I don't like statins in women. I don't think statins do a good job in women. I mean, the only time I like a low dose statin is in a male under the age of 75 with proven coronary artery disease. In other words, bypass, angioplasty, stent. Remember, statins thin the blood. I'm not a big believer in a cholesterol theory of heart disease, but statins have a pleiotropic. In other words, by pleiotropic, they thin the blood, they reduce the blood thickness, and they're also potent antioxidants. I mean, let's face it, one of the best causes for fungal disease are statins. In other words, they're anti-inflammatories. Now, the drug companies can't sell you on blood thinning and anti-inflammatories. They can sell you on cholesterol. But statins do have an advantage, especially very low dose. I'm talking 5 or 10 milligrams. I'm not talking 80 or 100 milligrams of a statin. Only in the male. I really like statins in young men. And I think anything under the age of 75 is still young. So in your particular case, I would go to your doctor and suggest that, can we take her off a statin? I mean, I don't mind a beta blocker. Beta blockers do a lot of good things, but I'm sort of anti-statin, especially in Great Britain. They give statins to children. That really gets me excited. But I'm not a big fan of statins in women.
Okay, Zoom user, you're next.
Hi, can you hear me okay?
Yes.
Awesome. Hi, my name is Yogi. Thank you for that. I had a question about anti-inflammatory, essentially both foods as well as any supplements. I just want to get your perspective on what are some good anti-inflammatory essentially products. For me specifically, what happens is that I get very dry and sensitive skin because of that. And I also have high blood pressure, and I read your book. So I'm really excited to see if there's a connection between that and then how inflammation might be a factor.
Yeah, I mean, if inflammation could be a factor, I mean, I love anti-inflammatory foods, non-GMO foods. I mean, that's one of the reasons why I developed a food business on Vervana.com. I just feel that foods can be an incredible source of inflammation. I mean, everybody knows about people with allergy to foods, and even as a heart specialist, I encountered, peanut allergies and severe asthmatic and even cardiac arrests in people. So I am very privy and very, very sensitive to looking at foods. There's no doubt about it. I mean, sugar is the worst food you can put into your mouth. It's so pro-inflammatory. So any foods with sugar, I do like foods that, bring, anti-inflammatory situations to the table. Let me just name a few. For example, garlic and onions. I think they're so medicinal. Garlic and onions contain fibrinolytic compounds, allicin for one, and onions. I mean, and garlic, both thin the blood. They're anti-inflammatory. I just feel that there's so many foods, even avocados, for example, they have a lot of fat. They are great anti-inflammatory foods. One of the quercetin, I feel, is one of the best foods, even protecting against COVID-19. There's great literature to show that quercetin is sort of an antiviral. Now, where do you find quercetin? Well, you find it in onions. You also find it in green tea. Black tea and apples, green apples. There was a study that came out years ago. It was a Zuppelin elderly study. It came out of the Netherlands. I was a fellow in cardiology when I read it, and it went on for decades, almost like the Framingham study in Connecticut went on for decades. And it was the interesting thing about the Zuppelin elderly study, and you can go online and look at it, is that they were looking at death as the endpoint of the study. In other words, they didn't care if you died of heart disease, cancer, stroke. It didn't matter. They measured one endpoint, death. And what they looked at in these men was the flavonoid status in their bloodstream. In other words, the higher bioflavonoids, the higher quercetin in the bloodstream, the longer you lived. And then they looked at the diets of these men. And the men that ate the most onions lived the longest. And men that ate green apples or black tea lived longer too. So, when you look at these non-inflammatory foods, I mean, as a heart specialist, that's music to my ears because inflammation is the root cause of heart disease. So, like, for example, kale. Kale is one of the best foods to have nitric oxide. In other words, it supports nitric oxide in the body. So I'm all in on kale. Sardines is a great food for it's an animal food, but sardines contain a lot of DMAE, which supports the brain, and they contain a lot of CoQ10. Migratory salmon, loaded with CoQ10, Could there be a radiation factor because of Fukushima? Yes. But if you get your CoQ10 from, let's say, Great Britain or Ireland or, the North Sea, that's still, pretty healthy area. So I like using foods as creating a high vibrational status in the body. And I'm all in on foods. And one of the things I did at Vervana is olive oil, for example. We use olive oils from California. And I'm looking at an olive oil from Greece right now. But we use olive oils from California because our olive oils get certified by the California Growers Council. Remember, a lot of the olive oils in Western Europe are cut with canola oil. And canola oil is a pro-inflammatory oil. In other words, that's not good, And the problem is olive oils, if they have 25% or less of canola oil, the label can say 100% extra virgin olive oil, which is not a good thing, So olive oil, to me, is one of the best foods. And the reason why I say that is if you look at longevity in the world, Okinawa used to have the monopoly on longevity. Okinawa right now is surpassed by Spain, Portugal, and Italy. In other words, they are surpassed by the olive oil nations of the Mediterranean diet. And if you look at olive oil, what does olive oil do? Well, olive oil changes pro-inflammatory genes. In other words, we all have pro-inflammatory genes in our body. And basically what olive oil does, extra virgin olive oil, it takes pro-inflammatory genes and it reverses the pro-inflammatory state to a non-inflammatory condition. So if you look at the Mediterranean basin, doesn't matter whether you live in Israel, Libya, Greece, Italy, Tunisia, Morocco, that doesn't matter. These people, there's more 100-year-old people in the entire world than the Mediterranean basin. And that's why I put olive oil into my staple. And I'll just show you. I'll just get this out of my cabinet. See, I practice what I preach. This is my olive oil varietal from Vervana. This is an organic varietal that we get from California. And I just feel that for anybody listening on the call, I mean, the architect of the Predemed study was Dr. Gonzalez. The Predemed study was a study that was done in Spain, and it showed that if people drank, let's say, 4 tablespoons of olive oil a day, that's a lot of olive oil, 4 tablespoons a day. Or if they went on the American Heart Association diet, or if they went on the Adventist diet with nuts, so to speak, a lot of nuts, the group drinking the 4 tablespoons of olive oil a day and the Seventh-day Adventist nuts group far did better than the low-fat American Heart Association diet. These people had less diabetes, less Alzheimer's, less stroke, less heart disease. It's amazing, right across the board. And the Predemed study has been recapitulated, as they continue to look at the data. So when Dr. Gonzalez, and again, I'm on the board of the American College of Nutrition. When I invited him to lecture at our annual conference, my colleagues and I started drinking olive oil. We've been doing 4 tablespoons a day ever since we heard him lecture. That was about 5 years ago. So I'm all in when it comes to olive oil. I mean, as a pro-inflammatory, as an anti-inflammatory food, it's one of the best. So remember, any of these foods that contain a lot of fat, you don't require insulin to metabolize fat. Remember that. So in other words, if you take in more healthy fats, like a monounsaturated fat, like olive oil, or more healthy proteins, you get less of an insulin response. And we know that insulin is the most pro-inflammatory hormone. So less sugars, more healthy proteins, more healthy fats, more healthy fruits and vegetables. That's the way to eat, and again, that's why, and avoid GMOs as much as possible. And that's the way I think we should be eating in the 21st century going forward. And again, and again, not to be long-winded on this, But that's why I developed Vervana.com, because our pastas come from Italy. We use a red lentil pasta, which is a high protein pasta, a chickpea pasta, and we use different sauces, and everything's organic and no chemicals, no BPA. You don't need that stuff. I mean, my God. I mean, I think eating clean is going to be the biggest challenge of the 21st century.
That's brilliant. How do you spell Vervana? How do you spell it?
Vervana, Vervana.com. You'll see all my foods.
It's in the chat. So make sure that if you're listening to this and you want that information, just save the chat to your computer and the website link will be there. Okay.
This is brilliant.
Okay.
It's a fun website to really do.
Hi, I have a father. He's 81 years old. He had a stent implanted about a couple of years ago, and he's on statins. I finally convinced him to lower it from, or lower it, and on beta blockers, and also on, and his symptom is, and like when you were talking about one of your patients that actually, you put him on the stress test and he has the symptoms, afterwards, he would go, he's a big hiker, right? He hikes mountains and he doesn't have that many issues when he's hiking, but then like a couple of days after, almost he feels like he gets like kind of an attack or feeling really bad for days after. And so listening to you, I had this hunch that maybe with him, it is all about, ATP, but what would your recommendation be of how should we start with the CoQ10, with the ribose, the mounts, and maybe like, I've been trying to get him to maybe lower more and more some of his statins and everything else. And his cholesterol levels are really low, but his cardiologist would not get him off the statins.
Yeah. What's his brain like?
He's very sharp. At 81, he currently is pretty sharp. But
Good.
He does take, he takes a lot of fish oil after my recommendation.
Good.
But, my worry is that for him, the hiking is his social outlet too. And now all the doctors are telling him not to hike anymore. So I'm like, can we, supplement a little bit for him in order to be able to give him that opportunity to still hike and not have these kind of somewhat attacks like a couple days later?
Yeah, here's what you do. Give him, get some ribose, R-I-B-O-S-E, D-ribose, and give him a teaspoon in, let's say, a glass of water before his hike, okay?
Okay.
And give him a teaspoon at the end of the hike.
Okay.
And then give him at least 1 or 2 teaspoons a day following the hike,
Okay.
In fact, if he's 80 years old, I would give him at least 1 teaspoon a day.
Okay.
And what's happened to him is what happened to my patient on a treadmill. His body requires ATP, and the de novo synthesis is requiring days, and he's feeling exhausted and probably fatigued and everything else. So, and remember, statins cause also, these myalgias as well. So I think, give him at least a couple of 100 milligrams of CoQ10 and give him some ribose. I would also give him a little magnesium, and he should be as good as new. I mean, he should probably be able to do anything he wants to do.
All right, that's great. I'll talk to him tonight. He's actually in Europe, but I'll talk to him tonight and figure out how to get some of this to him. Thank you so much.
Okay. All right.
And if it works, he'll know the first hike he takes.
All right.
And
Excellent.
also tell him to listen to his body. I mean, one of the side effects, and I've seen this in marathon runners who use ribose, they feel like they're so energized that they'll want to, try to improve their times, and they'll just go all out. I don't want your 80-year-old father to do that. I want him to be moderate, if he's feeling energy, just tell him to put a lid on that energy, okay?
And then do you have any, and I saw a lot of questions about the brands of ribose and CoQ10 that you recommend?
Any ribose is good. I don't have, a special affinity to one. The CoQ10 that I like is what we have at Healthy Directions, but any high quality ubiquinone, the one you see on American TV, that liquid ubiquinone, that's Tishcon. That's the same factory that does the CoQ10 for me.
Mhm.
That happens to be a ubiquinol, but that's fine. I mean, that liquid ubiquinol is good, or liquid ubiquinone, any of them are okay.
Okay, great. Thank you.
Okay, Audrey.
Hi, my name is actually Jeff McFadden.
Yeah, okay.
I'm not sure why my mom's name is showing up, but I had a question about, I have a high calcium score, 243. I'm 67 years old, and I wonder if that would affect your recommendations any in terms of what to take.
Yeah, okay. Yeah, 243, it is getting up there. Is this the only calcium score you've had, just one?
Yes.
Okay, the thing that you want to do is take Metaquinone 7. Have you ever heard of MK7?
I have not.
Okay, do you live in the USA?
Yes.
Okay, MK7 is a vitamin K2. And basically what it does, it takes calcium out of blood vessels where it doesn't belong, and it puts it back in bones where it does belong. If you want to look at the research on MK7, there's two Dutch researchers. One is Leon Schrager's, Schrager's, Schurgurs, I believe, and CES Vermeer, Vermeer. I met these two researchers. I was at a Yale meeting, in New Haven, Connecticut about 15 years ago. I was a heart specialist in the audience. And when I heard this 15 years ago, it blew me away. They presented their data on MK7. And I ended up taking both these guys out to dinner on my own time. And not only took them out to dinner that night, but took them out a week later again, because after I had a chance to research the literature. And then because of them, I had an MK7 made at Healthy Directions. So I've been taking MK7 for about 13 years now. It's just amazing. MK7 is awesome. It really is. And again, I think the data on it, if you read their research, it's really a nutraceutical to take. However, you need double the dose. You need at least 300 mcgs a day instead of the 150, the standard dose, because whenever you have calcification, you should take the double dose. The other thing I would recommend it as a beverage is green tea. I think green tea is really awesome for plaque reversal. I also like pomegranate, and pomegranate juice or any forms of pomegranate. There's nice research to show in the Japanese literature on green tea showing plaque reversal, and for pomegranate as well. So try those two, fruits. It'll be good for you.
Wonderful. I'll be on it today.
By the way, what is your beverage in the morning? I'm kind of curious.
Unmute yourself. I just muted you.
Oh, okay.
No, not you, doctor.
Oh,
yeah. Jeff, go ahead.
I have one cup of coffee with caffeine, one without, and then a cup of black tea.
Okay. I like the black tea. If you can substitute one of your coffees for a green tea, that would give you a nice combination.
Yeah.
Try to develop a taste for green tea.
Is it better to skip the caffeine?
There's pro and con on this. A little caffeine is okay. It really is. I mean, if you want to have a cup of coffee, I see no problem with it.
All right. Thanks very much.
Okay.
Esteem.
Thank you. Excellent lecture. I'm really enjoying it. I had heard that L-carnitine can increase certain bacteria in the colon, which can cause cancer. I'm sorry, I don't remember the.
Yeah, it's the TMAO hypothesis.
Yes, that's it.
Yeah.
Can you comment on that, please?
Yeah, I mean, listen, like any, hypothesis or recent literature, there's articles that suggest that carnitine could be harmful, and there's other articles that are refuting all that research as well. I mean, one of the most difficult things about being a physician like myself is you can find 5 papers for something and you can find 5 papers against it as well. you know, and it's difficult to sort through what's real and what's not real. I look at it this way. I take carnitine. I like carnitine. You know, I read all the stuff on the TMAO. It doesn't make any sense for me. And I'll tell you why it doesn't make any sense. Why would the kidney make carnitine in our bodies? Carnitine is made naturally in our bodies. Why would our body naturally make carnitine if it's going to hurt us? It's like our bodies make CoQ10. Why would it hurt us? It's like, you know, our bodies, you know, do make ribose in a monophosphate, you know, hexomonophosphate shunt, you know, only for, you know, ATP production. In other words, I get really concerned when literature comes out on a substance that's naturally made by the body. That bothers me. The other thing that bothers me is that the research is, and I don't know if I should say this on the air or not. I don't know. I'm taking a chance. But the researchers who reported on this own patents on this, you know, so there's a little bit of conflict of interest there, you know, on this whole hypothesis. These are the guys out of the Cleveland Clinic. And look, these are bright guys. I mean, I'm not going to throw them under the bus, but the same Cleveland Clinic, by the way, reported on a meta-analysis. These are clinicians. These are not PhDs. These are doctors, right? And clinicians. The same Cleveland Clinic, and you can look at it in the literature, reported on a meta-analysis of carnitine increasing survival in heart patients. And this is a meta-analysis of thousands of patients. So, like I said before, there's a lot of you know, literature for and against, but I take carnitine. I love carnitine. And acetyl L-carnitine, by the way, is fantastic for the brain. And I like L-carnitine for the heart. I like propionyl L-carnitine for the heart. I mean, I just think, and if you want to get carnitine naturally, eat a lot of lamb. Lamb is the one food that contains carnitine. Not mutton, not old sheep, but young sheep or young lamb. Beef has very minimal quantities of carnitine. So I hope I haven't confused you, but like I said, when it comes to the TMA, and by the way, have you ever heard grandma say that eating fish is good for you?
Yes.
Well, fish is loaded with TMAO. Did you know that?
No, I didn't.
So
fantastic.
If you want to read a good rebuttal by an Australian journalist, his name is, oh gosh, I'm having a senior moment. Let me think of his name. He's from Australia, and he wrote a scathing, I mean a scathing rebuttal of the TMAO hypothesis. I can't remember his name right now, but if you go on Amazon.com and you look at cholesterol, he's written The Great Cholesterol is Con or Controversy or something like that, and he's from Australia. He's a pretty bright journalist, pretty bright guy.
Great. Thank you so much.
Michelle.
Thank you, Steve. Dr. Sinatra, thank you so much for a wonderful presentation. I have a comment and then a question, if I may. And the comment is on earthing and what you were saying about a sacred site. 30 years ago, I was visiting the Vatican, and at some point of time, I felt something pulling on my feet and my lower legs. And I asked the guide what was under where we were standing. And he said, that's where the popes were laid to rest. So I always had a belief after that, you know, if we pay attention of where we ground, we can really see what's good for us or not so good. So that was my comment. Question is, I've been interested in CoQ10. I have a history of traumatic brain injuries and brain bleed. My heart is perfect. I'm 60 years old. And my blood also is fairly thin. And so anyways, I was wondering actually if that would be a good thing for my brain, because that was the reason why I wanted to take it.
Tough question, because see, CoQ10 has some blood thinning capabilities, very, very slight, very, very slight. But you had a hemorrhage in the brain, like an aneurysm?
I had a traumatic brain injury, and I had a brain bleed on the top of my brain.
Like trauma, you mean like a car accident trauma or a sports injury or something? Or
yes.
Well, that's different than do you take any CoQ10 now?
No, I have not, and but I would like to. I take fish oil and DHA, and I just saw your article on your website, can adult grow new brain cells, and so I thought maybe.
I mean, I like CoQ10 for the brain. I mean, I think it's vital. I mean, I don't see any problem taking, low doses. I mean, certainly you can take 30 to 60 milligrams or, I mean, I don't see any problem with that, in that range. You're still at a young age and, your body's still making it. But again, I really like CoQ10. It does great things in the body. So, and they're using it in a lot of brain stuff. I would read that paper. That last slide I showed?
Yes.
The neurological aspects of CoQ10 are huge. I mean, Downs, Parkinson's, Alzheimer's, Huntington's chorea. Do you realize I was at the conference where they were given 2 grams of CoQ10 to Huntington's chorea's patients, and these patients were feeling better and there was no side effects. So I don't see any reason why you couldn't take 50 milligrams of CoQ10 a day at all, believe me. So anyway.
I will definitely.
But read that paper, get the paper. It's on the slide and, read about the neuropsychiatric, neurological aspects of CoQ10. That'll be really privy to you.
I have another suggestion too, is that you might want to get your blood clotting and coagulation parameters measured to know whether or not your blood might be on some level too thin, in which case you might want to consider lowering your fish oil when you try the CoQ10.
That's right. Good suggestion. Wonderful. Well, Dr. Sinatra, thank you again, and thank you for your generosity. I appreciate it.
Thank you, Michelle.
Violet, you're next.
Hello, can you hear me?
We can, so good.
Awesome. Thank you so much for presenting today, Dr. Sinatra. I've been a fan for many, many years since the Sinatra Solution came out and have your grounding book and loved learning how STEP finally healed from all of the mystery illness so long ago.
Oh, yeah. He's still healing, that's for sure.
Well, that brings me to one of my questions. I have more than one. I don't know if you're comfortable on the air, but I know you consulted a lot of physicians during that time, and I have unexplained chronic illness, but a lot of it is due to heavy metal toxicity and have been really challenged finding an excellent holistic doctor to help, preferably on the West Coast, and was looking for some top suggestions.
What heavy metal are you toxic on?
There's a few due to routine playing in crop irrigation ditches during childhood. So there's arsenic, mercury, lead, cadmium. There's a lot.
There's a lot. And how are you getting the heavy metals out of your body?
Well, there's a lot of impaired detoxification going on, and I haven't been able to work with a physician who can help with methylation and all kinds of, mitochondrial dysfunction. There's just not enough cellular energy to make it happen, right? So I really want to work with a great physician. And so I was looking for your top recommendations of who I might reach out to. I'm on the West Coast in California, but telemedicine is fine.
My son Drew is a naturopath. He used to work in Mill Valley, and now he's in Canada. He's worked with a lot of detoxification, and he does work with heavy metals. There's a clinic in Mill Valley. Where in California again?
Northern California, not far from the Bay Area.
Oh, okay.
But again, telemedicine has doctors everywhere, and those that maybe even specialize in chronic and pathogen infections, mitochondrial dysfunction, impaired detox. I know a lot of people in the audience also deal with, similar issues at times, and really love to look into good physicians.
Yeah, he worked with an internist. She's board certified internist, probably in her mid 50s, which makes her real sharp. That's a great age because you have enough experience. No, you have enough experience under your belt, and you're humble enough to realize that there's a lot more to learn. You know what I mean? So
I love it.
When I see a physician between 5.0 and 6.0, I really like that. Her name is Beth McDougall, and she's at the Mill Valley Clinic. It's in Mill Valley. Maybe you could reach out to her And if you can't find her, maybe Steve or anyone can send me your email, and I can get you the information. But if you live near her, she's really big in detox. So it's hard to find a good internist that's is involved with detoxification. But she works with naturopaths, and naturopaths, that's a natural for a naturopath. It really is. And
Perfect. Thank you.
And she has naturopaths in her clinic, so that might be a good fit for you.
Excellent. Thank you. I appreciate that. I will do. The next question I have is, I love that you mentioned that you had prescribed CoQ10 for a lot of your heart patients. Do you have some suggestions on how to get insurance or prescription for CoQ10 so it's covered?
Yeah. No, I really don't. I really never had that issue come up, so I'm so sorry.
Okay.
I mean, CoQ10, the good news, especially the Tishcon varietal, it's not expensive. It really is not expensive. I go into health food stores and I see CoQ10 on the shelves, decent CoQ10s for like $20 a month, which is not a bad price to pay for your health,
Oh, not at all. I was just thinking for my family member who has a cardiac problem. He's on stents, so I'd like to see that as part of the monthly refills.
Yeah, any good, ubiquinone would be good for your family member. No doubt.
Perfect. Awesome. The next thing is D-ribose. I've had problems tolerating that due to dropping blood sugar. It can really dramatically drop it, right?
How are you taking it? In water or in orange juice?
It was, I think, the Corvalin, and it was in water.
Oh, take it in orange juice.
Or a different beverage.
Take it in orange juice, and if you want to add a little maple syrup to it, you should be fine. But she raises a very good point. I want the audience to understand this. D-ribose is sugar, but it causes a negative hypoglycemic effect. So in diabetics who take D-ribose, it can lower the blood sugar, despite the fact we call it a sugar. So it has a negative glycemic effect. And some of my patients, and I had hundreds and hundreds of patients on D-ribose when I was practicing on a day-to-day basis. I would hear this occasionally. At least once every 2 weeks or so, where one of my patients would say, I get a little dizzy, I get a little lightheaded, and again, orange juice, and add a sugar to the orange juice, like a maple syrup, and you'll be fine.
Wow, so paradoxical. Okay, thank you so much for your time. You've been wonderful. Great slides.
Okay, and good luck with the CoQ10.
Thank you.
William?
Can you hear me?
Yes, you're up.
Great. Doctor, I'd like to ask you, I am on a baby aspirin and I take 40 milligrams of Lipitor. I had a stent put in 1.5 years ago. Am I eligible to take MK7, and how much is the dose? Or will it thin out the blood too much?
No. You can take MK7. I've had a ton of patients taking aspirin and even on statins, low dose statins. Again, in a male, I like a low dose statin. I would take MK7 if I had a stent. I would.
And would you take it twice a day, 150 milligrams each time, or what would be your dose?
I personally take 300 micrograms in the morning. First thing in the morning. That's the way I take it.
Got it.
Yeah.
Thank you. Really appreciate it. Thank you.
Okay, I've got a question here about testing blood thickness. Looking at, let's say, red blood cell sedimentation rate, or would you have other suggestions for monitoring that issue?
I used to measure blood viscosity. Who was a researcher that did that? Kenzie? Was it Kearnsey? Yeah. I think blood viscosity is the real deal. And, a sed rate just measures inflammation. It's probably a very, very poor index of blood viscosity, but there are ways of measuring it. I guess an indirect measure would be a dark field analysis of your blood, where you can take a drop of blood and put it with a little saline and look at it under a dark field, and the blood should be not in clumps, but it should be moving, you know? In other words, when red blood cells repel one another, we call that the zeta potential. Think of a traffic jam in the middle of San Francisco and New York City for that matter. That's a poor zeta potential. In other words, those cars are stuck. But if you think of the Autobahn in Germany where the cars are going like this, that's a good zeta potential. So in other words, you know, we want our blood to be thin. We want our blood to be, we want those red blood cells to just repel one another instead of clumping together. And one of the best things for that is really earthing and grounding. I mean, we did the research. And when I did that research, I thought in 50 years of being a doctor, and I've written books and papers, and oh my God, I've written so many white papers. That was the greatest paper I ever wrote in my life, but none of the journals would take it because they didn't believe it. I mean, I think thick blood is a major risk factor in cardiology, and grounding is one of the best ways of thinning the blood. So it's free as well. So I'm all in on grounding.
Hi, Dr. Sinatra. What is your opinion on replacing baby aspirin with 200 milligrams of nattokinase?
Well, why are you taking baby aspirin? For what reason?
Because I had a heart attack.
You had a heart attack. Okay. All right. Well, you know, it's still, if you had an MI, that's still a gold standard. I'm not in favor of baby aspirin in healthy people or aspirin in healthy people at all. I've seen too many GI bleeds. I love nattokinase. 200 milligrams of aspirin and nattokinase, you don't want to thin your blood too much. You know what I mean? Especially if you take omega-3s and stuff like that. If you're tolerating the aspirin well, you like the aspirin?
Well, I'm doing a few experiments for myself, and I dropped the baby aspirin a few months ago, about 3 months ago, and I've been doing nattokinase twice a day, along with some other things that would thin the blood, like fish oils and things like that.
That's all right.
Of course, I don't want to put myself in a danger zone either, but.
Well, are you postmenopausal?
Yep.
All right. So that's out of, do you bruise easily?
I do bruise easily, and I'm really very healthy. It was quite a mystery to, I have 3 cardiologists who all saw me. They were quite surprised that I would have a heart attack, but I do have LPAs. I have LP small a.
Oh, that's the worst risk factor. And
yeah.
Okay, yeah. You see, yeah, that's the worst. Believe me. So I like the fact that you're taking anti-inflammatories and thrombolytics. I like that a lot. Yeah. So when you blow your nose, you ever see any blood?
Rarely. Maybe in the dry winter I might see it, but very rarely.
Okay, so that's your barometer. So basically, you have a good baseline. If you started to bleed from the nose or blow your nose and you saw blood, if you saw blood in your urine, then you have to back off.
Okay.
And I would continue to do what you're doing. You know, I mean, it sounds like and if you're bruising easily, you know, if you bang into a chair and you see a big bruise, that's also an ominous symptom. So back off on heavy bruising or bleeding.
Sure. Just to be clear, I'm not doing the baby aspirin in conjunction with the nattokinase.
Right.
I've dropped the baby aspirin and taken the nattokinase.
That's fine. I like that.
Okay, thank you.
Yeah.
The
other aspect of bruisability is weak collagen. So you might want to consider how much vitamin C you're taking, or the breadth of your bioflavonoid influence, or copper or silicon as trace elements that are involved in the maturation of collagen.
Yeah, Stephen, you've actually helped me significantly with reducing the bruising with the collagen and vitamin C. So thank you.
Now, Steve, are you a clinician?
No, but I write about nutrition and I research it all the time, but I'm a tertiary researcher. I just monitor the emerging literature.
Yeah. What's your opinion on copper, on taking too much copper in the body?
Well, I think that there's a major mistake that most people that are practitioners believe that high ceruloplasmin means copper toxicity. And I think that's not true. I think that that basically means copper sequestration, and that whenever you have inflammation, your body is going to sequester iron, copper, and zinc, and that can be actually low copper bioavailability. So I'm a strong believer that that you can test this with transdermal copper to see how you react. And if you have, let's say, a joint complaint, a pain signal somewhere in your body, and you put transdermal copper on it and it goes away for a day or two, that's a good sign that you have a poor copper bioavailability, and that it might be due to sequestration and chronic inflammation.
Right, right. Yeah, the reason why I asked the question is that with this coronavirus, a lot of people are taking zinc, and I happen to like zinc a lot. I mean, I think zinc does a lot of good things for the body. And I think a lot of people are short on zinc. The problem is if you're taking too much zinc, can that disturb the copper zinc relationship in the body?
Totally.
Yeah, and there's a lot of supplements that contain 2 to 4 milligrams of copper, which I think is a big dose. So, like everything else, I guess there's a sweet spot when you're mixing these nutrients together.
If you haven't seen it yet, there is a copper product called Ache Relief, which is basically dealing with an over-the-counter pain remedy, but it uses copper as an indicator for the penetration of the material into the skin. And it's produced by a company called youngerphenotype.com. And it's the best copper product I've ever used, even considering the copper peptide products that are out there that use the natural copper peptide formulation in the human body.
Okay, I'll check that out, Steve. That's good.
And that's a good way to balance out so if you're doing 200 milligrams of zinc a day for COVID, a little bit of transdermal copper keeps it
right
balanced.
Yeah.
Especially since it's not going through the gut where it can get sequestered by the liver on first pass.
Right.
It's going through your skin, which makes it immediately bioavailable.
Yeah, fortunately, I'm doing about 20 to 40 milligrams of zinc a day. But anyway, you see, a lot of these supplements contain zinc, and a lot of supplements contain copper. So, and a person like myself, I take a lot of stuff. So I add them up, and I just try to balance them best I can.
And zinc is so important for innate human response, for the activating your vitamin D and vitamin A receptors and turning on your nuclear transcription factors, and then activating that as protein. You need zinc to make that protein. So it's an absolute must for first line of defense against viruses.
I agree, 100%.
Yeah. Okay, so next is back to Susie.
Yeah, back to the beginning. So I just wondered if you could talk, Dr. Sinatra, and it's been fabulous so far, but talk a little bit more about the grounding. So you're just going outside when it rains, or do you have, you said something about sleeping grounded. So do you have any kind of shoe guide or something, or what do you recommend?
Silver sheets.
Yeah, I ground as much as I can. I walk on leather shoes only. It's only rare that I'll walk on a sneaker, but I walk on leather shoes, and when I walk outside, I try to walk on concrete, or remember, asphalt is man-made. That will not conduct the Earth's surface. In other words, brick, grass, sand. I mean, when I'm in Florida, I love to walk the beach, and when the tide's coming in and the sand is wet, you get all those minerals in the tidal water. So I try to ground as much as I can. When I'm on a computer, I have a grounded foot pad I put my feet on. I sleep grounded. I have a grounded sheet. Let's see. I just ground as much as I can. When I had a hip replacement 12 years ago, I'll never forget it. I came out of the hospital. I was in the hospital one night, got discharged the next day, and my right hip was like I mean, my right thigh was twice the size of my left thigh. And as soon as I got out of the hospital, it was in June, fortunately, in the Northeast, I sat outside and put my bare feet on the grass. And I slept with patches on that double size thigh. When I woke up in the morning, all the swelling was gone. I got to tell you, it was unbelievable. I had the swiftest, easiest post-op course of a total hip replacement than anybody in the world, I think.
Wow. So
yeah, and water is part of that process. And if you have a grounding rod out in your yard somewhere that you're connecting to, if you take some Epsom salt and some potassium salt and you mix it up in water and dump it on top of the grounding rod and water it, that salt will go down into the ground and massively increase the groundedness of that grounding rod.
Yeah, interesting. Yeah, interesting. Yeah.
Wow.
I ground whenever I can. I believe, I've worked with the researchers. I published a few of the studies. I mean, I believe in grounding and earthing 100%.
So where do you get you said you have a sheet that's grounded and you have a pad for when you work on the computer. So do you have those on your website or where do you get those?
My son is involved with it. I'm not. I mean, I think I'm on his advisory board, but he thinks grounding saved his life. I mean, he's all in. He lives in Greece right now. He's very electrosensitive. He's one of the 5% of the population. He used to work on Wall Street. He got very, very sick with EMF and computers and cellular and cordless phones. And what saved his life, because he lost over 100 pounds and got very, very sick. I thought I was going to lose him. I'll tell you, being a doctor, and it was awful. I have to tell you, it was awful. He developed septicemia, had no blood pressure. Oh, he said to me, he was dying, and he said to me, "Dad, would you put your bare hands on my heart and give me your chi?" That's how much he was devoid of chi. And I prayed and I prayed, and he got through it. He got through the night. But he's all in on grounding. He put out a lot of videos, and I think his website is grounded.com. I think that's his website. And he's done a lot of work with earthing, and he believes it saved his life. So that's why he just runs everything himself, and I stay out of it.
But you get to, so you use his.
I get his stuff myself, And Clint Ober also has another website, earthing.net, I believe. That's
somebody put that in the chat, I think.
Yeah, earthing.net.
Yeah, save the chat, definitely.
Yeah, grounded.com, earthing.net,
Darrell, you're next.
Yes, hi, thank you very much. Dr. Sinatra, the recent dietary guidelines didn't change saturated fat, the percentage. We know you were one of the earlier persons speaking about, the benefits of good fat, but what about saturated fat? And my other question about CoQ10, is there a better, do you like black pepper? Do you like olive oil? Or do you really feel that black pepper is the best form if you're going to put it with something? Would you rather it be olive oil, black pepper, or what do you like the best?
Well, black pepper has biopyrone in it. And biopyrene. And basically, black pepper is used with some of these varietals to enhance the absorption of the product. So black pepper is fine.
Okay. All right. Thank you. The saturated fat, are you a big proponent of adding more than the 10% that they allow, or you more for the monounsaturated Mediterranean, or do you support adding more saturated fat, being that the heart runs on stearic acid, which is pure saturated fat?
I don't have an issue with saturated fat.
Okay.
Here's the issue. Saturated fat forms cholesterol. But like I said, sugar is the enemy. Sugar is the one thing you want to avoid. So when it comes to the diet, I would much rather have monounsaturated fats. Certainly trans fats are out. Omega-3s all in, right? But if you have more than 10% saturated fat, like 20% or even more, I see no problem with it. Saturated fat will increase your cholesterol. There's no doubt about it.
Right, but
But it'll also increase the better aspects of cholesterol. In other words, the fluffier type, as opposed to the highly inflammatory type.
Right, and that's
Coconut is fine. I'm all in on coconut, and a lot of coconut is saturated fat as well.
right. Is PQQ really this much better version of? I mean, is that really all that it's made?
I'm sorry, you didn't come through. Say that again.
Is PQQ as good as CoQ10?
Oh, PQQ. You know, but you can take PQQ. I don't have a problem with PQQ. It's not a CoQ10 though. I mean, it might help the absorption and stuff. I mean, it's an energy type of molecule. I mean, I've taken it in the past. I like it. I mean, I'm not taking it now, but if you wanted to take it, I see no problem with it.
The LP little a is really genetically determined, and that's why. Do you have any other markers? Like, for example, the MMR LabCorp, the particle size, or the myeloperoxidase, which is expensive, or the plaque-2, or even just the oxidized LDL. Do you have any ones of those that you
They're
like?
all good. No, they're all good. They all bring something to the table. In other words, most patients have inflammatory mediators in their body. I'll tell you that. I mean, I used to do those blood tests all the time from Boston Heart, and I used to use the place in Texas. I forget some of the names.
SpectraCell.
No, SpectraCell. Yeah, I used to lecture for SpectraCell years ago, and I think they do a great job. But like a lot of these inflammatory mediators, very few times did I see people with zero inflammatory mediators. You know.
Yes.
Lots of times people have a couple or several, and my job as a clinician would be to put a few, fingers in the dike, so to speak, try to plug up some of the worst inflammatory mediators.
Yeah, this is the age of inflammation.
It's the age of inflammation. There's no doubt about it. That's why I really like CoQ10 so much. You know, it combats NF-kappa B, interleukin 6 and C-reactive protein, and LP(a). CoQ10, I think, is going to go down as a miracle nutrient of the 21st century. I really do. That's why I believe so heartily in CoQ10.
Huh. Well, thank you very much. Thank you.
Susan, do we have any questions that have been floating that I've missed in focusing on raised hands?
There are a lot of questions, but once people stopped raising their hands, I didn't track it because I figure it's better they talk directly to him himself. So
we're also 15 minutes beyond the normal time frame for this. So, Stephen, how's your stamina doing?
I'll be the last man standing.
Love it. Well, there are a lot of questions, but anybody whose question wasn't answered, why don't you raise your hand now? I'll have to leave in about 20 minutes to go to work, but that shouldn't stop anything.
Okay, we have two questions that just popped up. David?
Hi, I'm here with David. I'm his wife, Maria. Hello.
Maria.
Dr. Sinatra, I've been meaning to meet you for years. I've been, we're fans of all your books, and we have a doctor that is a big fan of yours, Dr. Woodson Merrill in Manhattan. Anyhow, but I don't know if it's possible to still see you or you're not seeing patients, but I had a very important question. Why don't you like statins for women? I'm trying to avoid them for years, but now I'm at the point where I might not be able to because I had surgery this summer for diverticulitis. And right after that, my cholesterol shot up to 300 something, 305. And then I started taking red yeast rice, whatever you call it, 4 capsules a day of these made by Thorne. Anyhow, it really did a number on my liver enzymes somehow. So I stopped it, and now I'm very worried about all my cholesterol is up in the clouds, the bad LDL and all that. And I'm going to have to see the cardiologist. They're going to want to give me Crestor and all this stuff, and also or the injection they have now called Rapatha or something or other.
Yeah.
I'm just, and I do have plaque in my left descending artery, in my right coronary, and now they saw it in my aortal artery. They saw some plaque in there.
And how old are you, Maria? How old are you?
I'm 68.
68. Anybody in your family die of a heart attack or a stroke?
No.
No, huh? And
My
anybody
brother-
have longevity in the family?
My longevity, yes. My dad died at 90. My mom did get pancreas cancer at 82. My brother got a stent in his early 70s. And I've had high cholesterol for a long time, but unfortunately, they saw, I once had an angiography a long time ago, and they saw a 30% plaque in my right descending. And then in 2017, 60% occlusion in my right coronary. So I'm not sure how I've been trying to avoid it by taking the red yeast rice, but it's apparently bothering my liver.
Oh, that's
If it's bothering your liver, you don't want to compromise liver in this day and age with viruses all over the planet. You got to keep your liver healthy.
Yeah.
If you were my patient, I would put you on MK7. We talked about that on the program. I would definitely take it. I would take 300 micrograms a day. And when it comes to a statin, you're already on red rice yeast. It's a form of a statin, and your liver didn't like it. So if you were my patient, I wouldn't give it to you.
No.
Now, let me tell you something about cholesterol, and I hope there's a few people listening to this. Let me say it this way. I was part of the Framingham study in New England. And that's a study that started in the 1960s, 70s, I believe, or 50s. And all these board certified cardiologists in New England, including myself, believed in the theory of cholesterol and heart disease. And we all thought that the people in the Framingham study, where they followed these people for decades, I mean, from 50, 60, 70 years. Well, guess what happened? The people with the highest cholesterols lived the longest. I saw cardiologists, board certified cardiologists, becoming psychotic. They couldn't believe it. They couldn't believe the data. They were going nuts. And let's look at COVID-19. Children with MRSA staph, MRSA, the worst possible staph, deadly in children, kills children because there's no antibiotics that treat it. Children with the highest cholesterols survive MRSA staph because cholesterol is for some reason, it prevents infectious disease from killing the body. Same thing is true when I wrote my book, The Great Cholesterol Myth. We were looking at these gastrointestinal infections, and people with the highest cholesterols were getting less gastrointestinal infections. I'm talking about these 24-hour viruses and stuff like that. So Maria, it sounds to me that you're living in an epidemic of COVID-19. You're living in New York City, and New York City has had its share of problems. Maybe having high cholesterol is God giving you a gift right now. Maybe let's reframe it. Let's look at it as a plus instead of a minus, despite the fact that you have some plaquing of your coronary arteries. If you were my patient, who cares what your cholesterol is? It might protect you with COVID-19. Somebody will do that research, I'm sure. Take MK7 and try to do a little plaque reversal. Drink some pomegranate juice, drink some green tea, eat a less carbohydrate diet, take in less sugars, and try to, be your own doctor and manage this yourself. But to take an injectable medication for your cholesterol right now,
no.
It's up to you and your doctor. I don't want to, like I said, you're not my patient, but A high cholesterol might be a God's silver lining for you right now.
Yeah.
Especially if it's not oxidized.
Exactly.
But it doesn't the LDL, if it's high, it's about it's the bad cholesterol, the LDL, is the oxidized?
It's different.
If it's oxidized and it's LDL, it's inflammatory, yes. But remember, that's one of the reasons why you take CoQ10. It prevents the oxidation of LDL.
Okay.
You know, that's the thing. And I don't want to confuse you, Maria. You know, like I said before, you go to 5 different doctors, you're going to get 5 different opinions. But if you had a 90% plaque, I'd be a little bit more concerned. But 30 and 40%, and you're 66, I mean, maybe you can talk one of your doctors before they inject you with a cholesterol substance. Maybe they can do a nuclear stress test on you and see how, you know, what your functional capacity is and see how far.
My stress tests are usually pretty good. I've been exercising 5 times a week and taking my heart rate to 160 for years.
Oh, now you're singing to the choir. And 160 is like max for you. It's too much. I would only go to 130.
Yeah, well, I take it to my top capacity and I do like interval training for half an hour. I was doing that.
Oh my gosh, you're the real deal athlete. You're the real deal jock. Interval training as well.
Trying to avoid the statins, but then in June I had a terrible diverticulitis attack, and
yeah, well, that could be due to the statin.
Yeah. And I had 4 abscesses and a perforated intestine, and then I had to have surgery. I'm wondering if that cholesterol that went up to 305 was to protect me from all that infection in my intestine.
Yes.
Yeah, I would say so. Like I said, cholesterol, it's not the enemy that we think it is. That's why Johnny Bowden and I rewrote our Great Cholesterol Myth book.
Yeah.
People, gosh, I mean.
It can help you with your healing.
Yeah. Exactly. That's what somebody mentioned, a chiropractor that I saw said, you know, it could be because of that infection and the surgery you had that it went so high for a while. Anyhow,
you're right. After a heart attack and after surgery, cholesterol rockets.
Yeah.
It's a protective mechanism.
And
remember, cholesterol's in your body to protect you.
I'm going to try to do diet to help myself, but I'm very confused about Esselstyn, nor these other 2.
Oh, Dr. Yeah. Dr. Edelstein. Yeah. ESS.
Yeah.
Esselin. Yeah. Something like that.
No oils, no nuts, no nothing.
Oh, look, he's a good guy. I like him. I've been at conferences with him. He and I have opposing views. Yeah. I prefer my view over his.
Yeah.
I mean, look, if you want to be a pure vegan, I got no problem. But for God's sakes, have a little animal protein. You know, at least once in a while, a little fish if you can. You know.
Yeah. No, I cannot do it. I have never been able to even attempt that diet. Yeah. But I will check your diet recommendations before I do statins. Anyhow.
Yeah, do the Mediterranean diet. Go to my website, drsinatra.com or vervana.com. I have so much written on the Mediterranean diet. I mean, I love the Mediterranean diet.
Okay, and the MK7 and the CoQ10.
Yeah, take those too. That's what I would do.
All right.
Really.
Well, thank you so much.
All right.
My husband has a 3,000 calcium score, and he won't take the statins.
Yeah, and I'm about to be 80.
Okay, well, we have 2 people who haven't asked questions before.
I wouldn't mind a 5 or 10 milligram dose in him. I really wouldn't if his calcium score is 3,000. But you know what?
Listen.
I tell you the truth, your belief is so important here. So, you know, let's go to the spiritual side of medicine. Belief is important. So
I agree.
All right. Good.
Les.
Yes, thank you. I missed the earlier comments about atrial fibrillation. I'm helping my wife treat atrial fibrillation as a deficiency disorder. And the main components of that are DHEA, taurine, and L-arginine. And that got her from almost continuous AFib to episodic, maybe once a week to once a month. And I started adding in things like carnitine, CoQ10, and so on. And that seems to help. Right now, she's about 97% of the time in sinus rhythm. So I'm making progress, and the times that she goes back into AFib, I'm not sure whether it's depletion of something that occurs or whether she's encountering a new trigger that we just haven't figured out yet.
What's
Comment?
the EMF like in your home?
Uh,
Any cordless phone?
any what?
Cordless phones?
Yes.
Yeah, throw the cordless phones in the garbage. Get rid of them. I have had more patients get close to a cordless phone during a call, develop atrial fibrillation than you can shake a stick at, you know? And not only me, my colleagues as well. Yeah. Environmental EMF is a big source of atrial fibrillation. And get a corded phone, get a Princess, $15, $20, that's all they cost. Plug it into the wall. Get your computers wired, you know? Because one thing about EMF that I do know in atrial fibrillation, the heart is vulnerable to EMF. And when the heart is vulnerable to atrial fibrillation, maybe the potassium's low, maybe there's too much adrenaline going on, maybe your wife is thinking about a thought that's giving her unpleasant thoughts. I don't care, I don't know what it is, but if you put, it's a perfect storm. If you put those situations in a high magnetic field with EMF, it could trigger atrial fibrillation. And that's why it can be episodic. So, you know, think about that.
Okay, thanks. We just got a new cordless phone for Christmas. But the other
See?
thing
That's God in your life right there.
but and she hasn't gone off the rails because of it yet. The other thing we discovered is that sulfites seem to be a trigger.
Oh yeah, yeah, I get that. I can see that. Yep.
Yeah, those are oxidizing agents,
Yeah.
and it's CoQ10 and is a reducing agent.
Yeah. In fact, when my son made wine in California, he had to go with sulfites, and he went with the lowest possible amount of sulfites you can use because sulfites, you know, they're toxic, especially if you drink wine.
Well, that used to be the case for my wife. Lately, she is off of wine completely, and I suspect that sometimes when I use wine just as an additive to cooking, that even that might tend to upset the apple cart a little bit.
Yeah, the heart's very sensitive to that stuff. No question.
You can actually test that with the wine. There is a formulation using L-cysteine, N-acetylcysteine, glutathione, and vitamin C in the conjunction of drinking the wine, where you're adding all this reducing power at the same time you're exposed to the sulfite and the acetaldehyde from the wine. And if it shuts down the reaction, you know that it's the oxidation of the sulfite that's triggering the reaction.
Steve, that's a good point. So in other words, I love N-acetylcysteine. I mean, I think N-acetylcysteine is awesome. You know, it's amazing. I've been recommending it for years. I take it myself all the time. Now the FDA just came out. They're stopping it in supplements. And if you look at NAC, when you take NAC, it helps form glutathione in the body, right?
That's right.
And if you have glutathione and you have a little selenium and vitamin C on board, now you're going to form glutathione peroxidase, which is the major immune enhancing antioxidant you can possibly take. So taking NAC, I love NAC. And you're the first person I heard of saying that taking NAC might interact with sulfites and alcohol.
Yeah, it's also,
I didn't know
this
that.
is the first year that a double-blind placebo-controlled study of NAC and vitamin C combination on hangover remedies has now validated that technology that was originally discovered in 1975.
Yeah, you add selenium to that and you got the perfect antioxidant. It just makes sense. A hangover remedy. I gotta remember that.
How about
you taught me something. I like to learn on these things myself. You know what I mean? NAC, alcohol. That's great.
Okay, we have one more person here.
All right, one more and then we're done.
Okay, Pat, you're the last question. Pat? Okay, apparently Pat isn't responding. Okay, how about admin?
Thank you. You can hear me, admin?
We can.
Yeah, and you're the last question of the day.
Last question.
Thanks so much. I typed a message on there about the NAC. You just said it's going to be unavailable, but I'm doing liposomal glutathione, so maybe
Oh, I like that. I like that. That's great.
Okay, so that's a side question. I asked this of Steve, and I wanted you to, since you were promoting grounding so much, and I've been using my grounding screwdriver stuck in the earth with a cord going all the way up to my bed with a copper fiber fabric attached to my body. But if the fat, and that's my grounding system for sleeping, if the fabric is not wet at my end, it's not working. Isn't that correct?
I would say that if you sweat at night a little bit, it is wet, and a little bit of sweat helps, or a little bit of moisture does help, yes.
I mean, I just feel like I've gone to all this trouble, and if I'm really not sweating that much, and I figured, you know, is there a way to test this grounding?
Yeah, there is. You got to get in touch with Clint Ober, and I'm sure he'll talk to you. Just mention my name. He has a little device. It's a red light, green light, and it'll tell you if your shoes are grounded or if your sheet is grounded. You just plug it into the wall and you rest on it. I moved in Florida, and I sold my home, and I downsized to a condominium on the beach because I believe in grounding so much that I wanted to live on the beach, and I wanted to walk with my fly rod every morning because I like to fly fish, right? So when they were constructing the condominium, I took a ground floor, and Clint Ober and the engineers, I got them together, and I put a tile on my ground floor in my bathroom. So my entire bathroom is grounded with this tile from Italy, so to speak. And there's no cement in it. And it's tile on concrete, on steel, and the steel goes into the ground. So everything is grounded, right? And I was really curious to know. So Clint sent me the green light, red light, and it's just amazing. Boy, when I take a shower and I got water in there, I'm totally grounded. Because I believe in grounding so much. I think it's the essence of anti-aging medicine. And so I'll just put that out there. I don't know if your bed is grounded or not, but there is a way to check. I'll tell you that.
Let me also suggest that you may want to launder your silver, sheet with, do a final rinse without a final mix, without a spin, where you add some magnesium chloride or some magnesium sulfate to the water so that you're saturating the fabric of the sheet with some magnesium heptahydrate or magnesium chloride as a hydrate, and those will help you connect to your sheet.
So Epsom salts can work for that too. And
I suggested it as how to ground the grounding rod out in the yard, because when you're raining through things, you want something like magnesium or calcium because they hang out in the soil longer than salt does. And in sheets, the same thing applies. Salt rinses off very fast and doesn't hydrate well, whereas magnesium hydrates extremely well.
I have another idea. Why don't you go to one of the grounded websites, order a grounding sheet, and see what it's like. It's a good control of what Stephen just said. In other words, you get a grounded sheet, you can plug it into the wall if your house is grounded. They come with little lights. It's so simple. If there's two lights that light up, your grounded socket is good. And see how you sleep on a real grounded sheet. And if you sleep the same on your grounded sheet, then you got two grounded sheets. That's all. That's a nice little experiment you could do. Now you have a control.
I can't say that I am sleeping that well. I've got a smart meter near me and I don't know how to do it.
Oh, you have a smart meter? Oh, no. Oh, God.
Well, it's unfortunate. It's not.
Oh, gosh. How far away is that from your bedroom?
Well, actually, when I'm in my bathtub, my head is close to the wall with a smart meter outside, but then there's a bathroom, the length of a bathtub with a closed bathroom door could be closed. And then there's my bed. So I'm at least a couple bathtubs away from the smart meter, but I still don't know how to address it since my landlord won't let me remove it.
Well, can you put an aluminum screen between the smart meter and you and then ground that aluminum screen so that the smart meter communicates away from your house instead of into your house?
So I could just take the bathroom wall and put aluminum on it inside, because outside might deteriorate, or maybe outside put aluminum all around the smart meter except for how the guy has to read it.
Yes.
Yeah, the outside wall should the aluminum be shiny?
The guy doesn't have to read it. That's why you have smart meters, because it sends the information directly to the power company's computers. So nobody has to read it. But typically the smart meter is mounted on top of a metal box. So if you run the aluminum screen right up to the edge of the box and fasten to the wall and then ground that to the ground, then all the radiation that's pointed at you is being dismutated by the screen. And all you have to do is clamp the screen to the wire, because aluminum corrodes so readily. You have to have a very, very good mechanical connection between the aluminum and a copper wire to run it to ground.
Steve, you really notice stuff cold, man. Wow. I'm impressed.
Yeah, it sounds like the aluminum can't just be the aluminum foil that I bake with. I have to find some.
No, that works if you can connect it. But the cheapest thing is a screen door kit from your local hardware store for a large sliding glass screen door. It's like 4 feet wide and 7 feet tall. And if you get that behind your meter, you're now, you've screened basically your entire house.
I guess the landlady has to read the meter because it's their meter. That's why I can't get rid of it. It's not just for me, it's for their family. Otherwise I would opt out. So I guess I can place a big screen like you're talking about on the ground, leaning against the smart meter so she could.
No, it has to be behind the smart meter so that if it's in front of the smart meter, it'll prevent the smart meter from communicating with the power company, and they'll come and take the screen away.
And the only way you get it behind is to go on the inside of a house, because I can't take
it. You can mount it on the outside of a house if your landlord will let you do that.
Yeah, I have to remount that smart meter totally.
No, because the metal box that's on the wall is itself screening the meter.
Oh, okay, got it. I just have to get that aluminum all around the edge of the box.
All around the box.
Yeah, I'm gonna experiment. Thank you, Steve.
And it's like $10, but it's going to take you hours to install it. And grounding it, you need to drive a grounding rod in the ground or connect it to a gas pipe or something like that. That's has a pipe going into the ground in order to actually get it grounded, because a screen by itself floating in air isn't grounded.
Yeah, I guess I'll have to get the experts over here. Michael Newart is the expert in this North Bay area with EMFs, and pay his services, actually.
Another option.
Yeah, let's thank Dr. Sinatra for a marvelous presentation.
Yeah, this was a lot of fun. So anyway, have a happy new year, and maybe we'll do it next year.
Oh, we hope so. Thank you so much. And next week on January 14th, we have Jeffrey Smith at 2:00 in the evening Pacific time.
Thank you, Dr.
GMO.
And I put
Bye, everybody.
Get ready.
Bye-bye. Thank you.
Thank you.
Thank you
You
so
were
much.
wonderful.
And don't forget to
appreciate
save
you.
the chat. If you want that information, save your chat.
Thank you.
We appreciate you, Dr. Sinatra.